Good morning and welcome to the second day of the National SAS Doctors event, led by the Southeastern Division of the Royal College of Psychiatrists and Surrey and Borders NHS Foundation Trust. My name is Fatima Tekfi. I'm the East and Mid Rep for the SAS Doctors in Surrey and Borders NHS Foundation Trust. I've been working for the Trust since January 2012. Initially, I worked in the working age adult inpatient unit and home treatment team. I moved to the community mental health recovery service 4 years ago and took on the role of rep for SAS Doctors. As a part of the commitment of the Royal College of Psychiatrists in promoting and supporting SAS career development, our trust and the medical education team, amongst them Dr. Martin Schmidt, ex-DME in the trust, current Health Education England, Head of School for Psychiatry, Dr. Gillian Henry, Consultant Psychiatrist and SAS Tutor, Dr. Jeremy Mendekotwe, Consultant Psychiatrist and current DME, Mr. Ali Khan, Senior Medical Education Officer, and Ashley Calloway, the SAS and Medical Education Coordinator, have welcomed the initiative of being part of the fantastic joint event with the Royal College of Psychiatrists. We are very pleased to make this webinar come together despite this challenging time of COVID pandemic. I'd like to thank the audience for their attendance today, as well as the speakers, Professor Nandini Chakrabarti, Dr. Mike Groves, and Professor Mike Crawford, who have made the event program as outstanding as it is. A huge thank you for Karen Morgan, the Royal College of Psychiatrists Southeastern Division Manager, Ashley Calloway, the SAS and Medical Education Coordinator, and Mike Grove, the SAS Tutor in Southern Health NHS Foundation Trust. We couldn't have done this without them. Now I am going to go through a few housekeeping notes for you. Please use the Q&A box for questions for our speakers. The chat function has been disabled for delegates, but you may get messages from the hosts throughout the day. If anyone has a technical problem, they can put this in the Q&A box, and this will be dealt with as quickly as possible. Today's event will also be recorded following the event. The video link will be made available approximately 2 weeks following the event and be made available for 2 months following the event. There will be a break from 11:20 a.m. to 12 p.m. and I would kindly ask the delegate to return on time for the next speaker. Please set your view to speaker view, as this will give you a better viewing option. I would also be grateful if you could fill out feedback forms. A link will be shared in the chat at the end and will also be sent after the event. Your attendance certificate will be sent 2 to 3 weeks after the event. Please tweet through the event if you wish, using hashtag SAS2021. We had a great first day of this event yesterday and heard from our fantastic speakers about how to treat and manage some of the challenging mental health disorders in our day-to-day practice as psychiatrists and in this changing world. Dr. Pierce talked about personality disorder management for the general psychiatrist. Then Professor Baldwin addressed anxiety disorders. And finally, Dr. Geruna talked about treatment-resistant depression. All 3 presentations were so excellent and informative, and we have already received really high praise and fantastic feedback from the day. This morning, our focus will be on non-clinical, looking at developing and maintaining a high-quality portfolio for SAS doctors, with sessions on CSER application, influencing and leadership as a SAS doctor, and your role in clinical governance, I hope you enjoyed today as much as yesterday. Thank you very much for listening. I would now like to welcome our first speaker, Professor Nandini Chakrabarty. Professor Chakrabarty is a consultant in early intervention in psychosis services in Leicester and an honorary professor with the University of Leicester. She is Associate Dean of Equivalence in Royal College of Psychiatrists and works closely with the specialist registration applications team of the GMC. She has various other amazing roles. As Associate Dean of Equivalence, she bears responsibility for CSER dialogues with GMC and has been keenly interested in the recent changes to CSER combined pathways. Professor Chakrabarty is going to talk to us about an important process of a career development for SAS doctors. Her presentation on CSER in psychiatry will concentrate on the requirements of an application portfolio for CSER applicants in psychiatry and how supervisors, medical managers, and organizations can support you in making successful CSER journeys. A psychiatry CSER portfolio is different from an ARCP one, not in the terms of work done in clinical or non-clinical area, but in the way the evidence is presented. So without further delay, I'd like now to hand over to Professor Chakrabarty. Thank you.
Good morning, and thank you for that very kind introduction, Fatima. I'm going to start sharing my slides here. Right, can everybody see my slides, Fatima?
Yes, yeah.
Okay, thank you.
Thank you.
Okay, it's always a pleasure to talk about a CSER portfolio, and I mean that because a CSER portfolio is a habit for life. And I hope all of you who are listening to me today, whether or not you decide to apply for CSER is entirely up to you, but I hope that I can give you some tips about how to best evidence your work. All of you are busy clinicians. All of you form the part of a very hardworking, valuable workforce in psychiatry. And there is so much of work you do, which is not always documented, which doesn't go onto paper. And when you do a CSER application, it's about capturing every bit of work that you're doing, clinical or non-clinical, getting documentary evidence of it, presenting it to people who have never seen you in a teaching session, who have never seen you talk to a patient. Your portfolio has to speak for itself. But without further ado, let's get down to the highlights. So just as Fatima made a mention in the introduction, it's about what kind of evidence does a CSER assessor look for. The difference between a trainee portfolio and a CSER portfolio is not about the work you've done, but it's about how you present that work. The foundation of evidence is still the specialist curricula. When you are applying for a general adult CSER, you're still trying to match it against the general adult curriculum. So what you need to evidence, the level of expertise you need to evidence is still the same as somebody at the end of ST6 going on to consultant practice based on the same curricula, but how do you present it? And here I'm going to introduce the absolutely basic difference, which is primary evidence and secondary evidence. And this is something that you've got to keep in mind when you start a CSER portfolio. What is primary evidence? Primary evidence is the evidence that talks for itself. For example, if I see a GP letter that you've written, if I see a tribunal report, if I see some of your teaching slides, I can make up my mind for myself about the kind of clinician, the kind of teacher you are. Whereas secondary evidence are workplace-based assessments, references, 360-degree. It's somebody else telling me about you. It's secondhand information. So an ARCP portfolio, a trainee portfolio, is very much based on secondary evidence. The first thing an ARCP panel will look for are the educational supervisor, the clinical supervisor reports, the number of workplace-based assessments, the supervisor reports from special interest, research, audit, etc. Whereas a CSA portfolio is about primary evidence. You don't tell me explicitly whether you're a good doctor or a bad doctor, whether you're up to consultant practice or not. You give me actual evidence, actual documentation of the work you're doing, and let the CSER assessors make up their mind. Let me elaborate this a bit more. Let's say you do a GP letter where you start off with, I saw this patient on an urgent visit, on an urgent home visit, on the request of my CPN colleague who spoke to the family this morning and who have started expressing concerns that the patient might be showing signs of a relapse. So from that one paragraph, I can make out a lot of things. The fact that you're going out on an urgent home visit because a patient might be relapsing shows that you're a doctor who can prioritize. You're somebody who responds to emergencies. You're somebody who works with a team. You're supporting your CPN colleague. And that's the kind of evidence, that's the kind of finesse that you've got to give to your clinical work. Let's talk about the discussions we have with our patients. There's a lot more of discussion we have than we document. The discussions you have about lifestyle changes, the discussions you have with the patient on an antipsychotic who's gaining weight, the discussions you have about drug and alcohol, about smoking cessation, the discussions you have which have psychotherapeutic principles, the discussions you have with the family or a patient who's finding it difficult to accept a diagnosis. And we don't always capture the complexities, the nuances of these discussions. Our discussion becomes very much based for the GP. So as long as you are communicating with the GP about medication, about referrals, about what else needs to be done, we often miss out documenting the hard work, the complexity, the practices of a mature clinician going into that letter. And that is what you've got to capture when you are putting in letters within a CSER portfolio. And these clinical letters are going to be the backbone. They will constitute 90% of the weight of your CSER portfolio. A CSER portfolio is not about references. It's not about testimonials. It's not about lots of thank you cards. These all have their place, but they are still secondary evidence. Right. Okay. So going on to, we've talked a bit about ARCP and CSER portfolios, and basically where they differ is in the secondary and the primary evidence. The common pitfalls of CSER applications, we are going to talk about that, but the main pitfall is sometimes the focus and the work that goes into the secondary evidence instead of concentrating on the primary evidence. And I'm also going to talk a bit about how you can use the appraisal to focus on CSER, because CSER is a lot of paperwork. It's not a lot of extra work to what you're already doing. It's about maintaining that documentation, putting it on the portfolio. An appraisal is also a lot of paperwork, but you cannot get away from an appraisal. An appraisal is a compulsory thing that all of us have got to maintain. And how can you use the appraisal process to focus on CSER, stop reduplication, and run them in parallel? Right. So the documentary evidence that you've got to give is about attaining the competencies outlined in the specialist curriculum. So right from the beginning, ILO 1 is about history taking, ILO 2 is diagnosis formulation, ILO 3 is management, ILO 4 is risk assessment and mental health act assessments, mental health legislation. So you've got to document each of these competencies individually through documentary evidence. Some of it will obviously overlap. For example, if you have a clinical letter or a tribunal report, that's going to cross across all the clinical competencies. But what you've got to keep in mind is that the competencies have to be individually, and all of them have to be attained. There is no halo effect in the competencies. For example, a lot of people ask us that I have worked as a locum consultant for 10 years. Will that take off my CSER? Or I do teaching for the local university, I carry out a particular module, and is that going to take off my teaching competency? And my answer is go back and read the curriculum. There is no one thing which creates this halo effect which will tick off your whole application. The application has to be based on the individual competencies that you have. If you don't have an MRC Psych, you've got to give evidence of having attained core competencies. So what does that mean? If you have an MRC Psych, which was attained at any point in your life, whether it was 10 or 15 years ago, or whether that was 4 or 5 years ago, it's not a problem. But as long as you have an MRC Psych, you can forget about the core curriculum. However, if you don't have MRC Psych, you've got to evidence both the higher curriculum that you're applying for, let's say old age or CAMS or general adult or whichever, and you've got to evidence the core competencies as well. Now, this might seem a lot of work, but actually when it's broken down to practicalities, it's not much. Think about it this way. When you're evidencing non-clinical ILOs, leadership, teaching, research, there is no way you can attain the higher curricula, the higher competency, and not fulfill the core competency. You can't show that you have attained leadership at a higher level, which has not maintained the core competency. The gap comes within the clinical ILOs. So within a core competency, within the core curriculum, you are expected to have touched upon at least general adult, one of the neurodevelopmental specialties, so LD or CAMS, and some old age. So if you do not have MRC Psych and you are applying for a general adult CSER, you've got to submit some cases of old age and CAMS or ID. Or if you are applying for old age, you've got to give some of old age and a neurodevelopmental specialty ID or CAMS. And it's just a few cases, 5 or 6, and they can be done at core level. Having MRC Psych makes your paperwork slightly simpler, but I would also like to reassure you that our statistics show that even without MRC Psych, the chances of passing your CSER are still the same. Our applicants are roughly 50-50 MRC Psych, with MRC Psych and without MRC Psych. The pass rates amongst these two groups are the same. They are proportionate. So there's no way to believe, or don't be discouraged if you don't have an MRC Psych, and don't let anybody tell you that not having an MRC Psych reduces your chances of a successful CSER. It does not. You just have to give us some cases which complete the core competencies. The evidence has to be within the last 5 to 6 years. And at this current point with GMC, this is non-negotiable. So other than your MRC Psych, which does not have an expiry date, the other evidence, all the cases, even the cases for the core competencies, have to be within the last 5 to 6 years, and it's last 5 to 6 chronological years. It's not whole time equivalent, it is chronological 5 to 6 years. Next slide, please. Right. Now, let's talk a bit about eligibility in application. And most doctors don't have a problem with this if they have done training in an in a recognized training number at core level at some point of their lives. And again, this doesn't have an expiry date. To be eligible in a CCT specialty, so within the 6 CCT specialties we have in the college, general adult, CAMS, old age, forensic, psychotherapy, and intellectual disabilities, within these 6 specialties, to be eligible, you must have taken 6 months of continuous training in the specialty undertaken anywhere in the world, because the CSER applications are an overseas, they are an international thing, not just for the UK. Or you have a specialist medical qualification in the specialty obtained anywhere in the world. And MRC Psych is that qualification which will let anybody apply for a CSER. If you don't have an MRC Psych or any postgraduate qualification in psychiatry, you must have had 6 months of continuous training in a recognized post undertaken anywhere in the world. Next slide. Right, and I'm going to talk a tiny bit about a non-CCT CSER. So CSERs can also be applied in non-CCT subjects, but these are mostly taken from overseas doctors who have niche specialties which don't exist within our list of CCT specialties in the UK, though they can generate evidence from the UK. To give an example, so if somebody from a place in Europe or somewhere else in the world where, let's say, for example, they have a neuropsychiatry rotation, they can apply for a non-CCT CSER in neuropsychiatry to the GMC. But if they were working in the UK, they have the overseas experience that has to be there in order to qualify them for applying, but they can work in the UK and generate evidence from the UK as well. The reason why I say this is because there might be a small minority of doctors working in very specific areas like eating disorders, rehabilitation, liaison, where you don't have a CCT specialty for what you're working in, and your work is pretty circumscribed within that niche. If you had an overseas qualification or 6 months of overseas training in that subspecialty, you could apply for a non-CCT CSER in that particular specialty. And the practical advantage of doing that is, let's say if you're working in liaison or you're working in rehab, you're working in eating disorders, often there are some SAS doctors who find it difficult to generate the breadth of the curriculum they are applying for because they are in such a niche area. So somebody working in rehab wanting to apply for general adult would have to go out of their proper rehab posting to try and gain experience of the entire breadth of general adult psychiatry. That's one of the pitfalls of CSER applications we do see, where people have generated evidence only from the place that they work in, and it doesn't cover the entire breadth of the curriculum of general adult or old age if they are working only in patients or outpatients or in a particular subspecialty. A non-CCT CSER is a possibility if you manage to get 6 months of overseas training or an overseas qualification in that specialty. Next slide. Okay. I'm going to talk very briefly about what the equivalence committee of the college do and who looks at your portfolio, so that you have an idea about how these people are going to come to a decision about your portfolio. So there are 2 evaluators who take up your portfolio once it comes to the college from the GMC. These evaluators are consultants. We have consultants from across the country in different specialties who are part of the equivalence committee, which I chair in my role as Associate Dean for Equivalence. And 2 assessors, 2 evaluators look at a single portfolio individually without conferring, to give the doctor two absolutely independent opinions. The two opinions then go back to the college coordinator, which is Elizabeth Boxall, and Elizabeth then puts the two templates together and finds out where the assessors have agreed and disagreed. For the competencies where they might have disagreed on an outcome, a variance report is compiled, and the assessors now talk to each other, trying to come to a consensus. And once they come to a consensus, then we sign off the template. If they can't come to a consensus on any particular competency, then as Associate Dean for Equivalence, I take the casting vote. And I finally sign off all the reports, have a look at how they've been written up. And the role of an evaluator is quite interesting because they have to evidence every statement that they say. So they can't write sweeping statements like the doctor's histories are not as you would expect from consultant level or ST6 level, or they can't write a sweeping statement to say that the histories are excellent. They have to quote particular evidence, particular case histories from particular page numbers to say that this is what the doctor has submitted, this is what they have written, and based on this evidence, our decision is that the competence has been met as per the curriculum or not. So it's almost like a medical legal report. Everything that they say has to be substantiated. Next slide, please. And so this is how the CSER application process looks. At the first big circle over there, that is the application received by GMC. And this application at the moment can be electronic, it can be in paper, it can be a combination of both. And it's unlikely that this process is going to change in future. I don't think it's ever going to become completely electronic to keep it fair for doctors all over the world, so as to speak. Now, 2 days are given for more evidence to be submitted. The first assessment takes place. And what we mean by this first assessment is, at this point, the application is lying just with GMC. And the GMC have a specialist registration team who are our closest colleagues in this work that we do. And they are non-medical people, but they have the expertise that you find within, let's say, the postgraduate coordinators that you would see within our within our HE, within our trusts, within our education departments. So even though they won't have the medical expertise, they do have a general amount of experience to look at a portfolio and pick out the big gaps, or at least make out whether the portfolio is legitimate or not. So does the applicant have the basic applying criteria? Do they fulfill that, having a specialist qualification or having at least 6 months of training? They have a look at that, whether the person is eligible to apply in the first place. So after that first assessment has taken place, 14 days to put in all the other evidence, and then the GMC takes 30 days to assess that evidence more thoroughly. This is the point where the assessors might come back, the GMC caseworker might come back to ask the candidate to brush up on the CV, can ask them to give, let's say, more cases, or pick out things like, you've not given us much teaching material, you've not given us any audits. They can pick out big gaps. And this is also the point where every applicant will have a GMC caseworker within the Specialist Registrations Committee who will work with them right up till the end. And this caseworker is somebody who you want to have excellent relationship with. And when they ask for more evidence, it's not because they want to make your life difficult, but because they want to give your application the best chance of success. So at the end of 30 days, the caseworker will issue a checklist to say, these are the more documents which we think you need to submit, and how thoroughly a CSER applicant has done their previous homework will dictate how long this checklist is. And then they have another 60 days to submit the extra evidence which has been asked for. It doesn't have to be 60 days. If you can do it quicker, it's done quicker. Or if you've done your homework really well, you can get away from this stage. And then the caseworker goes through it again. And this 60-day cycle can repeat if the applicant is not giving the evidence as asked. Ultimately, when it has been decided that all that could be done has been done, the GMC close the application, turn it to a PDF document, which is sent to the college, and 49 days they have where we send it to the two evaluators, they do their independent assessments, they confer, they come to an agreement, I sign it off, and then GMC does a quality check for up to 41 days. So from the time an applicant gets a letter to say that your application has now gone to the college, they will get a decision within 3 months. So that's how your portfolio gradually builds up. Next slide, please. So I'm going to talk more about primary evidence over here. So the examples of primary evidence are clinic letters, tribunal reports, medico-legal reports, minutes of meetings attended. And the minutes are not just to show your attendance. We want to see a person who is proactive, who's chairing the meeting or taking up action points, is contributing, is seen as being involved in a process. So not just shadowing a meeting, that doesn't give us more about how you would function as a consultant. We want to see your psychotherapy summaries, not just supervisor reports, not just SAPEs and psychotherapy ACEs. We want to see more than your teaching slides. We want to see your teaching slides combined with the context in which you are doing your teaching, with the feedback forms, with a reflection. Whether you do an assessment of teaching, whether you submit a workplace-based assessment alongside is up to you. But what we need to see more is that flow of how you got involved in the teaching to how you delivered it, to the feedback and your reflection. That should be enough. Now, at this point, I'm going to explain one of the points that we've often come across in CSER applications, which applicants don't seem to realize straight away, which is the teaching competency. If you go back and read the higher curricula of the college, the CCT specialty curricula that you're going to apply for, when you read the teaching, competency, the demands, it is more demanding. It asks for more than you would guess, whereas the research curricula is actually much easier to fulfill, to satisfy than people would ordinarily guess. And that comes through because people don't always read the curricula. People have this kind of notion in their head of what satisfies teaching and what satisfies research without actually reading the curricula. And that is something that I'm going to stress over and over again. If there are two things that you're going to take away from this presentation, it is go back and read the curriculum, the competencies, the intended learning outcomes line by line, and produce primary evidence for it, not just testimonials. There are no assumptions over here. So let me explain. What does the teaching competency actually look for? The teaching competency is not simply about delivering teaching. It's about delivering teaching in different models. It's about organizing teaching. It's about showing that you as a mature teacher can actually pick out a teaching need within a certain population, that when you're given a certain topic to teach to a particular group, you think about what kind of model, what kind of teaching style fits best for this group. So what we want to see in your teaching evidence is not just lots and lots of slides, but things like, let's say, for example, I see an email that you've written to your team manager to say that I think our care coordinators could benefit from a discussion, a session on metabolic monitoring for patients on antipsychotics, so that we can work together better as a team to make sure that people on antipsychotics, patients on antipsychotics, have better metabolic monitoring, and we can coordinate the organized tests better. So your team manager writes back to say that that is an excellent idea. We see more correspondence about how you have gone about organizing the teaching, and you decide that the best way to deliver this teaching is through slides which give us the current protocol about metabolic monitoring, leaving some question and answer time at the end. And then you get the feedback, then you do a reflection. Your team manager writes about what an excellent topic, doctor, and thank you for recognizing this need and delivering it. Right. That can be one kind of teaching. The other kind of teaching might be that you are invited to do a topic for medical students, and you are told that your topic is psychiatry history taking. And then you decide, how can I make this creative? How can I make this interesting for medical students? You might decide to go with a lecture, or you can do a lecture plus simulated history taking, or you can do a lecture with a simulated video. You can do lecture with role play. You can do a workshop type of presentation. So you can deliver it any way you like. There's one-to-one teaching that we do with medical students, with people who do work placements with us. And all that kind of model, all that kind of variety actually builds in. And so what we need to see is that you can identify teaching needs in different professional groups, deliver teaching in different styles, that you think about the teaching style that you're going to deliver in, you reflect on it, and you collect the feedback, you change your teaching style, you do your next teaching in a different way depending on the feedback that you get. Teaching is also about organizing. You might not always deliver teaching, but you might also decide that, you know, this is a training need within my team or within my group. I'm going to invite a speaker who is knowledgeable on the subject to meet this teaching need. And that organization is also part of your practice, your behavior as a mature teacher. So that's what teaching is about. It's not just about delivery of teaching. Research, on the other hand, sometimes what we get, the most common mistake, is giving us publications where the candidate, the applicant, is one of 8 co-authors, and I have no idea about what exact role they played in writing that paper, in doing that research project. They might have just done the data collection, or people do data collection as part of a multicentric project, but that does not give me an idea about their understanding of research methodology, critical appraisal, how to apply research to your practice. And when you read the curricula is not stringent about you actually having done research. It's about you as a clinician reading research, keeping yourself up to date, and being able to apply research to your day-to-day work. It's about you as a clinician being able to pick out your needs to read research on a topic. You've come across a certain clinical situation, a certain patient, you go back and you read the research about the treatment, the management, the presentation, and that changes your practice. So that's the kind of research experience that we are looking at. And the advice we give is, with the research curriculum, practically you could build the needs of your portfolio over a weekend. Take 4 papers in 4 different methodologies from peer-reviewed journals. 4 papers which you select, you give a reason for why you've selected these papers, because they are close to your practice, because you've come across a certain situation which needed reading in that aspect, in that area. And then you write a detailed essay on the methodology, do a critical appraisal, reflect on how this changes your practice, and that is what goes into your portfolio. It's not about doing data collection. It's not being one piece of the jigsaw in a large research project. It is about reading research, understanding research, and applying it to your practice. And that's the mistake that people make. Psychotherapy summaries. Again, the main mistake we see over here is people not giving us primary evidence. They give us lots of secondary evidence, workplace-based assessments, supervisor reports, but we actually want to see what psychotherapy went on, what actually went on in the sessions. And the reason for this is, remember, we are getting evidence, we are getting portfolios from across the world. Just a supervisor's report is really too thin on the ground for us to tick off somebody's psychotherapy competency, because we don't know what actually went on. Now, when you read the psychotherapy competency, which is ILO 5A, it asks the candidate, the doctor, to be able to deliver psychotherapy in a variety of models, and to be able to apply psychotherapeutic principles to their day-to-day practice. So some of your letters have to show formulations which have psychotherapeutic background. They've got to show management, discussion with the patient, which incorporates psychotherapeutic principles into your day-to-day work. But alongside that, basically what we need are 2 cases in 2 different models. They don't have to be a long case and a short case. They have to be 2 different models. That's all we are looking for. It could be 1 CBT case, it could be 1 EM and 1 EMDR. It could be 1 CBT case, and it could be a drug and alcohol group. People are using bipolar psychoeducation as in a structured way as one of their psychotherapy models. So if you have a doubt about the psychotherapy that you're targeting, whether this is acceptable for Caesar, by all means get in touch with us, email us and say that this is what I intend to do. Will it be acceptable? And I've seen people actually go out of their way, be creative, and sometimes search out models, search out opportunities of therapies that I've never heard about. But we are fine with that. If it's something that a candidate has shown the initiative, has shown the enthusiasm of going out and finding training about, and it's something that they are going to apply to their practice in future, we are all for accepting that, rather than going by the age-old 1 long psychodynamic case and 1 short CBT case. My other top tip for psychotherapy is try and do 1 individual and 1 group. And the practical reason why I say this is, when you go for 2 individual therapies, you just increase the chances of one of the patients DNAing midway, and then you lose the work that you've done. With a standing group on the ward, something like a problem-solving group on a personality disorder ward or a therapeutic community, you at least know that the group is going to happen. 1 or 2 patients might fall in or out, but the group is standing, it's going to happen. And again, what we need over here are a write-up of the sessions. Now, you can do it as day one, this happened, these people attended, this was the conversation, this is my reflection, this is how I contributed, etc. Or you can write a long essay on, I did 30 sessions between this date and this date on a weekly basis, and this is a summary of what happened over there. Sometimes with individual cases, people have given us a beginning of the therapy letter written to the patient or the GP, and an end of therapy letter alongside a reflection. So we are not fixed, we are not kind of set in stone about the kind of primary evidence, but it's got to be primary evidence. It's not just a supervisor's letter, and they have to be done within the last 5 to 6 years. So if some people have done something 8 to 10 years ago, I'm sorry, but that is out of date for a CSER portfolio. Next slide, please. Next slide. Yeah, thank you. So this, I think we've skipped a slide over there. If we go back to, yeah, lovely, thank you. So the secondary evidence does have its place. You will be asked to provide 4 structured references. They don't have to be full references when you do your application to GMC. What you do is you simply give the contact details of your referees, and GMC will get in touch with them with the reference template. It's a very structured, a very long template. So you need to you need to warn your referees beforehand about what is coming. Basically, the references are the 4 domains, and your referees have to write for every GMC domain to say how you fulfill this and what they've seen in your day-to-day work. One of your referees has to be the medical director or the clinical director. Now, sometimes the medical director or clinical director does not know you directly, but it's okay as long as they say that this is what has been told to be by the doctor's clinical supervisor. This is what I have seen in their appraisal records. That's absolutely fine. The other thing I would tell you is seek your referees on the basis of their punctuality and their willingness to answer emails. Sometimes a bland reference, something which says that, yes, I've seen no problems in this doctor. It's not glowing, it's not sparkling, it's not hugely complimentary, but it's just, yes, no problems there. That kind of a reference does not harm your chances of success. In fact, I will share with you some of our quite interesting experiences in CSER. It happens very rarely where, for want of better words, we get a strange reference, let us say a reference which suddenly says that I don't think this doctor has consultant competencies. I don't think we should employ them as a consultant. We've had it 1 or 2 times. And strangely enough, in both the cases I can think about on the top of my head, we actually overruled that reference on the basis of the primary evidence and the other references. So most of the time, what we get are histories, clinic letters, primary evidence with a few gaps in them, and we get references which are sparkling, really complimentary. But a complementary reference is not going to make up for histories which are not detailed enough, which are not gold standard enough. Whereas a basic reference, a reference which isn't that sparkling, will be overruled by great primary evidence. Your clinic letters are the first things that the assessors are going to read. And if your clinic letters are good, if your tribunal reports are good, if your clinical work is good, we will be kinder on the non-clinical evidence. If you do get testimonials, workplace-based assessments, appraisal records, of course, you're going to have that anyway. But I wouldn't say give a workplace-based assessment with every case. You don't have to. Give us a couple, 5 or 6 throughout your portfolio. And in fact, when we get overseas applications, we get none of the UK workplace-based assessments at all, but it doesn't put these applications at risk or, you know, at a less chance of passing, because we are based on the primary evidence. Next slide, please. Okay. And by this time, you're probably aware of what this slide is saying, that the primary evidence is key in the clinical ILOs, history taking, formulation, clinical management, risk assessment. We need to see the actual work that you have done. Now, in answering some of the queries that I know commonly come up within these teaching sessions, people ask us that I've written a history, let's say 2 months ago, which was a great history, but I missed out a fine point over there. For my CSER application, can I go back and tweak that letter to put it in my portfolio? And my answer is absolutely no. You cannot tweak evidence, you cannot tweak clinical stuff, because that is a probity issue. What you could do, if you wrote an excellent letter that you want to put in your CSER portfolio and you think that you missed out something, is that you write a reflective addendum to say that this is something that I forgot to document, but I did ask the patient, or this is something that I should have asked the patient, etc. But every piece of evidence you give has to be part of a real clinical record. You don't write tailored histories like a case report for CSER. You give us actual clinical records. Again, people tell us that within the burden of our day-to-day clinical work, within the business of our clinical placements, we don't have time to write detailed histories the way we should, the way we were taught. That is not an excuse for CSER. It's a bit like passing a driving exam. You have got to show us that you can check the mirrors and look over your shoulder and do all the exercises. After that, how thoroughly you continue doing them as a substantive consultant is up to your time and up to your clinical conscience. But for curricular needs, we need to see that you can actually do it by the gold standard. People ask us that, you know, again, can we tailor histories for CSER? And my answer is yes or no, in the sense, as I've said, that you don't just drag out notes and write a nice history gleaned on the information that you've got from the notes and present it like a case report to the, you know, to GMC and the college. That's not what we are looking for. But let's say you are seeing a patient in clinic today, a complex patient, and you think this would look really good on my CSER portfolio, and you just put in that extra effort to write a really good history. And that is allowed. You know, if you don't have time to write detailed histories, do detailed documentations on every patient you're seeing, and you want to concentrate on those that you are going to submit to your CSER portfolio and put more effort in it, that's fine. You are actually creating a real clinical record with more details than you usually should or usually would. But it is still part of a clinical record. It was still done in real time. In terms of how long does it take in this manner to make a CSER portfolio? And I would say that the best way to go by is first to collect your clinical cases, because this is 90% of the weight of your evidence. And once you've done that, the others flow. You're already within the practice. It becomes easier. It's making the start, which is the most difficult. And this is my calculation. In the busy jobs you do, I'm sure that you can churn out at least 2 detailed histories a week, whether you're doing it on an outpatient basis or whether you're doing tribunal reports on an inpatient basis, or a detailed discharge letter where you clarify where exactly your role has been in the patient journey. 2 histories a week, I think, is not much to ask of you. 2 histories a week means 8 a month. 8 a month means 24 in 3 months. By 4 or 5 months, you've easily got over 30. And our experience is that 30 is a good number of case histories, which gives the range of the clinical curriculum. So let's say for general adult, you're looking at inpatient, outpatient, emergency work, and it's emergency work. It doesn't always have to be out of hours, but it's emergency work, urgent work. You show us a breadth of the age range, from 18 to 65. You show us a range of diagnoses. Again, don't make it just specific to the area that you're working in. If you're working in early intervention and psychosis, we don't want a portfolio full of community psychosis cases. We want to see you going out to CMHT, doing a clinic 1 day a week to generate those cases of personality disorders, depression, anxiety, the range as we speak of. Similarly, for old age, we want to see a mix of organic, functional, inpatient, outpatient, seen in different clinical settings. We want to see a range of cultural diversity, and that is actually specified within the curriculum. We aren't making this up. We aren't putting this as an extra demand on CSER applicants. This is actually a curricular requirement. So make sure that if you're coming across people from a particular ethnic or cultural background, cultural background doesn't always have to be about ethnicity or race. And for example, working in Leicester, I could say that you sometimes have traveling communities. I've worked with some patients in farming communities, in remote rural farming communities, and they have a very different kind of approach to life, and dealing with the patient and family in that context is important. And you all do that on a day-to-day basis. It's about identifying and documenting it. And about this detailed documentation, I tell you, I have absolutely no reservations to demand this of a CSER candidate, because I think it's just good practice. Remember that, if God forbid, but if anything went wrong, if a patient made a complaint, or if there was an SUI, if there was any kind of adverse event, the thing that saves us, that the thing that gives us the logic to show the rationale of our actions is actually your good documentation. If it's not documented, it did not happen. And so I think there is no excuse in different settings to say that I don't have time to do detailed documentation, or my team administrator has asked me not to do detailed documentation. I don't think that's simply for CSER, that's for life. Remember, you're putting yourself on a slightly precarious ground if your documentation does not encompass everything that you're doing on the ground. And think about the way you gather clinical evidence for CSER being just a part of good habit for life. Next slide, please. Right. Now, there could be secondary evidence for things like leadership, team working, time management. And my key points over here are that do a fairly up-to-date 360-degree appraisal before you submit your CSER application. A 360-degree appraisal can help us tick off some things which are difficult in evidencing just through clinical work, things like team working, time management, leadership. Though if you get into the CSER mode of generating evidence, you could also generate primary evidence on this. For example, if you have led on a quality improvement project, if you identified a certain need, a gap in the service, you put in everything in emails about what you want to do, you lead on the project, you give us the minutes of the meetings that you've chaired, the actions that came out of it, the correspondence you had with various stakeholders in your trust, and finally the product. I think that's a good example of leadership, and something like that could take off your clinical governance, your quality improvement competency, and it could take off leadership as well. Team working comes into your clinical documentation in, again, how you work as part of an MDT in the different meetings, how you liaise with different people. Time management, we once decided that we were going to look at, so it depends on how GP letters are typed in different trusts, but there are GP letters where secretaries do say that it was dictated on such and such date. And if we regularly see a doctor doing their dictations straight after clinic and signing them off in time, yes, that's one evidence of time management, that they've put their tribunal reports on time, they answered their emails on time, that's great. And also, don't forget the importance of emails. Next slide, please. Next slide. Yeah. So now we did talk a bit about the CCT versus CSER differences over here. Both are based on specialty curricula. Both are dependent on experienced consultants, whether it's CSER evaluators or educators giving us a view. But in some ways, I must say that I find a CSER application a more objective way, because we are not depending on somebody else's opinion about you. It's about how you present yourself objectively to a set of people who know nothing about you. Now, again, coming back to, I was saying on the last slide about, the importance of emails, for example, and this is where you get creative about how you generate evidence. So it might be that your consultant gives you a good clinical supervisor report saying that, Dr. So-and-so is, reliable, takes up on clinical emergencies, always seeks advice where required, is a colleague that I can depend on when I'm on leave, etc., etc. So that can be part of the supervisor report. For a CSER portfolio, you can have an email correspondence with your consultant supervisor. Often there are lots of discussions that you might have in corridors about complex patients where you are holding the fort on your own, but you're doing the right thing by at least checking with the consultant who is the responsible clinician that, this is what I've done, is that okay? And the consultant might verbally say, okay, but if you are going for a CSER, you could ask, is it okay if I put that discussion in an email? And you can just ping me back saying, yes, great job, keep going. And so, there's this two kinds of evidence where one is the consultant perhaps telling us explicitly that this is what the doctor does. The other is generated by, let's say, emails, where we can see the discussion you're having with the consultant. We see that you do a lot of work independently, but you still ethically work within your remit, and you consult with your consultant where required. And that's the balance, the different ways in which you present your competencies. Next slide, please. Right. Now, we've been talking a lot about the components of the portfolio, the important components, the clinical cases, the teaching, the research, the quality improvement, stroke audit, the communication, the teamwork. But it's about breaking your work into small, manageable tasks and getting it off the ground. What I find in most CSER applications is that people have, stood for years thinking, I want to do an application and not making the start. And if you could go away from this presentation today and at least make a start and see where that takes you, I would think that I have managed to put my message across to you today. And again, I will reiterate my top tip, start with your clinical work, because you already have some evidence there. I don't think that, you know, if you're talking about your best clinical cases, which show your curricular competence as working at consultant level, that you've got to start from scratch. You already have evidence there. Start with the best cases that you've done in the last 5 to 6 years, start collecting them. And then it psychologically seems that you're not at square zero. You're already starting on the way. You are already way ahead. And it's just about polishing and fine tuning, identifying the gaps and filling those rather than starting from scratch. The other tip I've often given people is take some study leave, take a week out, block out your diary, don't answer emails, don't answer your WhatsApp calls, be absolutely stuck at your desk and start collecting the evidence that you already have. If you kickstart at that kind of blocked out time, you will find it easier to collect evidence once you get back into your busy job. You can do it along the way, but you do need some protected time to make that start, to get that headspace. Next slide, please. And about whether you want to do it in paper or electronically, I think electronic makes sense. You can also anonymize electronically. These are little things, but they make a difference. It's a lot more effort, and you are more likely to miss things if you print out your letters and you blacken them out manually, rather than getting the Word documents from your secretary and using a find replace function to put XYZ in place of the patients and, you know, their relatives' names. In terms of anonymization, also anonymize workplace-based assessments you've done for trainees as part of your teaching and assessment work. If there are, let's say, email trails to show that you have dealt with a complex MDT situation with a colleague, anonymize those names as well. So it's not just about patients, but any other sensitive information needs to be anonymized. And give yourself regular time to look into your evidence, at least once a month. Give yourself half a day to look in, match it against the curriculum, and see whether you have evidence for everything and what might be missing. Next slide, please. So getting started, that's the first thing. Length of an application, our average tip is between 1,000 to 1,200 pages is usually a good application. Not too long, not too short. CV has to be very detailed. You've got to put your job placements in reverse order. And you mention your clinical supervisor, you mention the number of patients that you're seeing, the turnover, the kind of case mix. I'm not going to talk too much about it because GMC will guide you on that. They've got a specific template and you follow the template, you follow the guide. If it's not up to scratch, your caseworker will guide you through it. So I wouldn't worry too much. The structured reports, as I've said, you want referees who are going to answer their emails, somebody who is ultimately going to write a brilliant reference, but will do it 6 months late and hold up your application is probably not a preferable choice. I wouldn't mind somebody who would write one-liners, but at least do it on time, honestly speaking. And you're going to go by the individual domains, and and our ILOs are grouped according to that. So the structured reports are written by the GMC domains, but the competencies go from 1 to 19 on most curricula at the moment. And you've got to fulfill every curricula, every competency in the curriculum. Next slide, please. As I've said, be creative about your evidence. And sometimes when we've had discussions, people have suggested things that I haven't thought about. So for example, there is this very tiny competence you will find in the curriculum, which is ILO 17C, about appraisal of others. Now, why that's there, I have no clue, because I'm sure nobody at an ARCP panel gets drawn up to say, have you done appraisal of other people? But this tiny bit is about doing a training for appraisers. So as long as you've done a training for appraisers and reflected on it, that's ticked off. Now, somebody at one of these training sessions said that, can I shadow an appraisal if the appraiser and appraisee are okay with it, and write my reflection on it? And I said, fine, if you can arrange that, that's absolutely fine. Or people come up with creative suggestions, as I said, about psychotherapy. They come about creative suggestions of how they can show the best of their strengths and expertise over the years. And all of that is fine. So think widely, think outside a tick box checklist. And that is crucial for CSER. You're generally looking at, I've got to fulfill the curriculum. I've got to present to people who don't know anything about me. And what needs to come out from that portfolio is the picture of a person who is proactive, who is clinically competent, who can deal with complexities on their own, but they work within their remits, who's a good teacher, who's a good manager, who shows leadership skills that we expect in a consultant. But it's all got to be done by the curriculum. And the importance of primary evidence. I mean, even till today, I still collect my best letters. And something that we reflect on within the equivalence committee is actually, as evaluators, we get quite mindful about the letters that we are writing. I know sometimes as consultants in busy jobs, the details fall apart a little and people start writing 2-page letters just with summary points to the GP. But when you get into the CSER process, you actually become mindful of, no, I want to do my best. I want to do my best documentation because that is fair on the patient. That is gold standard practice. And this is about being proud of the work that you do as a psychiatrist, showcasing your best. This is not just about paperwork. This is not just about a CSER application. Take a CSER application in stride with the perspective of, I want to be the best psychiatrist that I can be. And that is going to get you through CSER, that enthusiasm, that initiative, rather than looking at it as, oh my God, it's 1,000, 1,200 page portfolio of lots of paperwork and tick boxes, and this is too tiresome. It isn't. If you take it with the right attitude and the right enthusiasm, it's something that which will help you for life. Next slide, please. So structured report, we've already covered this. It's somebody who has direct knowledge of your work, and out of the 4 referees, GMC will tell you what is the minimum number of psychiatrists. If you want to include a CPN or a psychologist as one of the referees, it's not a bad thing at all, and it will not dilute the weight of your evidence, of your portfolio. Next slide. So keep abreast with the curriculum requirements. You must have heard that the curricula are changing. The new curricula are currently sitting with GMC to be stamped in August 2021, we are expecting. The moment they will be stamped, they will be applicable for CSER. But I want to reassure you that the content is not changing massively. It is simply being reorganized. It is simply being made neater. And if anything, I think it will make a CSER application, the way we assess CSER portfolios, a lot more streamlined. We are currently writing more specific guidelines, recommendations, which are written in line with the new curricula, and we will publish them straight away as the new curricula are published. But if you are going to start off work with the existing curricula at the moment, especially with your clinical cases, it's not a bad idea. Don't wait until August. Start getting your work done. Next slide, please. This is one of the most important slides that I would like you to bookmark when you get the slides around. And this is my advice of how to build a DIY portfolio, right? So if you do a big folder on your desktop or your laptop, wherever, to say my CSER portfolio, these pointers, these bullet points are your subfolders, right? And it might seem a very basic thing to say, but please, please back up your evidence regularly. The last thing you want is to be collecting evidence for 6 months only in one electronic place and the machine crashes and you lose everything. It seems such a basic thing to say, but it has happened. I have heard about it happening, and you don't want it to happen to you. Now, there is what we call a CSER portfolio on the Royal College website. Currently, I would simply say it is not fit for practice. Don't waste your time on it. We will rejig that portfolio, but we are waiting for the new curricula to come out in August, because it just seems too much work to do for a very short shelf life at the moment. But for the moment, if you use this slide, this guidance to build your DIY portfolio, then you can start getting your work done and then transposing it onto the GMC online site for application, or transposing it to the college portfolio when it opens up, will not be difficult, because it will more or less follow this order, so as to speak of. The other tip I would give you, if you are already collecting evidence, or when time comes for you to submit to GMC, try and reduce the number of documents in number. So for example, instead of putting your 30 case histories as 30 documents, put it as one document so that you don't lose the order. The more documents you give in, the chance is when it is transposed from, transferred from GMC to the college, the order will change and it will not come across in the order that you wanted it to appear. For example, if you want to show us not just one assessment, but a total patient journey where you've been involved. So you have the first GP assessment letter, you have a couple of review letters, you have a referral to another colleague, or the patient got admitted and you've got a tribunal report. For that patient, you want the documents to be in that order. You don't want the different documents to get scattered around. And since it's all anonymized, the assessors will not be able to make out that they all relate to the same patient. So making sure that all your case histories are actually one PDF document, even if it's a long document, but it's at least in the order that you want it to appear. So don't put in, let's say for teaching, don't put in one email, one document here, one document there. Make it all into one PDF document in the order that you want it to be read. That's another just practical tip for your application. Next slide, please. And as I said, that this is a time to reflect, and reflect properly. Do not be slave to your portfolio. Master it. Be enthusiastic. Make it work for you. Try to think, how do I evidence the best of my work? How does somebody read a portfolio and at the end almost have a vision of how I talk to a patient without them ever having seen me? Next slide. Okay, so on my last slide, I'm also going to just talk very briefly about the appraisal process and how you get organizational support. Now, there is a guidance for how organizations can support doctors working towards CSER. It's available on the college CSER pages as a guidance. That might give you the scope to negotiate with your organization. And it's also about helping you to use your special interest time in effective ways to fill the gaps of your portfolio, whether you need to do work in another clinical setting or whether you need to collect your psychotherapy cases. That's what you use your special interest session for. And talking about appraisal, as we said, that appraisal is a compulsory process. You can't get out of an appraisal. But when an appraisal PDP is signed off, and when it goes to your responsible officer, it almost gives the organization some responsibility to make sure that you are attaining your PDP, that if this is something that has been arranged between you and your appraiser and signed off by your RO, this is something that the organization should help you to attain. And if you tie up that appraisal process with your CSER application, if you sit with your appraiser and say, right, this is where my CSER application is, these are where the gaps of my portfolio are, and this is what I've got to attain over the next 6 months to a year in order to build my CSER portfolio, and you build your PDP by your CSER requirements, that gives you the organizational hold to ask for support. So 2 things: tie up your appraisal PDP with your CSER requirements. And secondly, look at the guidance we have on the CSER pages of the college, which is written for organizations, and use that to negotiate with your line manager and supervisor. And with that, good luck. And we are on to questions. Thank you. End of presentation.
Thank you so much, Professor Chakrabarti. That was really, really enlightening, I have to say. We have now lots of questions basically from the delegates, and I shall start with the first one. So we don't need too much workplace-based assessment number to ST4, ST6 requirement, please advise.
Yes, it's definitely not the number of workplace-based assessments which are specified according to ARCP needs. Give us a couple of workplace-based assessments, but we are not too fussed about them. Concentrate on collecting your clinical histories.
Thank you. Does facilitating a balanced group count?
Facilitating a balanced group counts, not just attending a balanced group, but if you are the facilitator, that could count as one of the models. But again, you give us a bit more about what's happening in a balanced group. I know that in a balanced group, we don't keep paperwork. That's part of a balanced group, that you don't actually do documentation, but you would be getting supervision for being a balanced group facilitator. So if you at least give us a supervision record of this is what happened in the balanced group, this is what we discussed at supervision, this is what I reflected on, then we have a bit of an idea of what went on. Give us 3 months worth of evidence, and I think that should be fine for one of the modalities.
Thank you. Another one, so should we print the notes from clinical system as evidence?
Yes, yeah, whether you print them or you collect them as Microsoft or PDF documents, that's fine. Clinical notes can be part of evidence, but it's not just a series of clinical notes. You've got to think about what you're trying to evidence over here. If we are trying to evidence the history of a patient, a new patient assessment is obviously what we are looking for. Now, some people tell us that we no longer do it as dictated GP letters. We are on system 1. So we just write on system 1 and that goes to the GP. So in that case, printing out the clinic note, which shows the documentation of history, or you've done an assessment on an inpatient and you have written in the clinical notes, but you've done the full history. Our trust, for example, has a template for history taking called the core mental health assessment, which is basically standard history headlines. So anybody from our trust would be generating that kind of a template. So yeah, that's fine, but we want to see full histories, not just disjointed notes.
Okay, thank you. Is evidence of participating in on-call rota, which means out of hours required for Caesar?
In the CAMPS curricula at the moment, there is a specific number. I can't remember on the top of my head, but something like 50 or so, where somebody has got to be part of the on-call rota. Within the other curricula, it's not that specific. So what we want to see is work in different clinical settings, as I said. And if you show that you have done work which is emergency or urgent, even if it has not been done out of hours, that's absolutely fine.
Thank you. Another one. I have done many interesting cases in last 5 years, but not written in very impressive ways. So should I leave these cases, though I can reflect what I learned and how it had changed my practice? Please advise.
Unfortunately, they won't be of much use if the documentation was not solid and detailed. I suppose if some of them are very, very complex, you might want to add a couple of reflections, but that would be more adjunctive. We really need to see the full history.
Thank you. If someone is working only in the community setting, do we need to work on an inpatient setting and show evidence?
Absolutely, absolutely. And that is, we are aware that is one of the difficulties faced by SAS doctors when they are working in just inpatient or just outpatient or in a very specified setting. And my advice there is that you don't have to go away and do a placement. You don't have to disrupt your clinical placement and go and do outpatient work if you're an inpatient doctor, etc. My idea would be to do 1 day a week in a different setting. So if you are an inpatient doctor, negotiate with CMHT that you will do a clinic once a week for them, and you will see only their new patients. I think anybody will jump at that. Or if you are a community doctor, you will follow your patient when admitted and do their tribunal reports, present to the tribunal, lead on their ward rounds. Again, anybody would, with open arms, accept that kind of help. The other place to get good general adult evidence, I think, is the crisis team, because they're always seeing complex patients. They're always seeing lots of different diagnoses, and sometimes the documentation, I'm aware, is done by nurses. But on this occasion, if you are helping crisis team for a day, you take it on yourself to do the documentation there, and that could tick off crisis, emergency, and doing lots of cases in the community as well. So that's just a tip if you could negotiate. So I would say don't disrupt your entire clinical placement unless you can do a full exchange with somebody 3 months against 3 months. But if you can't do that exchange, use your special interest session, and that is where you negotiate with your managers and supervisors.
Okay, thank you so much. I think we have to stop here. It was really very good and very informative presentation. We thank you so much for that. And for the questions which are not being answered, we will obviously be asking the speaker to respond afterwards, and we can forward this to the delegate. So thank
Fatima,
you.
I can give another 5 minutes. It's okay. It's just turned 11.
Right. Okay.
Give another 5 minutes. We can keep going. Yeah.
So let me get back then to my questions. Sorry, I lost the. Right. Okay. So thank you so much for such a clear presentation. How do we protect patient confidentiality in this process, even if names removed could not, I don't know what the details in psychotherapy summary breach confidentiality. Yeah, I think, sorry for that. I didn't quite get what they want. Yeah.
I would say that, use your common sense. And remember that GMC is going to check your evidence. And I can assure you that GMC is not going to put your registration at risk if accidentally you have left out a few names. They are not that harsh. They understand that within thousands and hundreds of pages of evidence, one name here and there can get missed. So whatever is acceptable for the GMC is acceptable for the college. And remember, again, this is not evidence which is going out public. It's also coming to organizations who have their own responsibility for confidentiality. But if GMC ticks it off as yes, possible, it's possible. So not a problem there.
Thank you. Another one, I worked in forensic inpatient for many years now and moved to general adult psychiatry community, and I wanted to pursue my CSER in general adult. Will my inpatient experience in forensic counts as inpatient experience? Thank you.
I think absolutely it should. I would still suggest that give us a couple of tribunal reports from an inpatient basis in general adult. But if there are cases in forensic that you have access to, then absolutely, by all means, use them.
Okay, another one is, I attended one training course focused on CSER, and the speaker mentioned the college was working in an online portfolio for us to submit all our evidence. Do you know anything about this?
Yes, I briefly mentioned that we've put it on hold until August, until the new curricula come out, when we can give much more specific, neater guidelines, because basically the 19 ILOs are going to go down to 9 HLOs. So, and all the duplication, there's a lot of duplication all over the curriculum at the moment. So what you're collecting right now, or if you're midway through your collection, it's not going to be a problem. You're still on the right line, but you'll be able to organize your evidence much neater and be able to identify the gaps and what more needs to be done and what you've covered or not once we are able to give those new guidelines. But we'll do it just after August when the new curricula are out.
Okay, thank you. Another question just from myself. For those who submit the review application, basically, how long does it take for the answer to be received from the GMC?
Right, yeah. The chart that I showed about the journey, giving the application 2 days for verifying, then 14 days for evidence, 3 months for checking, etc., etc. That journey is the same for application or a review.
All right, okay.
The difference is, and I'm glad you brought this up, Fatima, it's worth mentioning here that best chances of passing are on your review. So on the first application, roughly 30% pass, 70% don't. But I wouldn't just put your first pass or fail as just a pass or fail. If you have got away with just 5 recommendations, for the ILOs that you don't pass, we have to give very specific recommendations of what you need to do to complete the gaps. And within the review, all you need to submit are those recommendations. You don't have to put everything all over again. And our pass rate for reviews crosses 80%. Wow, so that's your best chance. So you've got 12 months to put in a review from the date of decision of your first application. But if you have very few recommendations, you can do it much sooner. You're obviously not going to take a full year. And though the chart is still the same officially, it just stands to practical reason that it will be done much sooner because it's a much smaller portfolio, depending on how many recommendations you need to fulfill.
Well, thank you so much for answering all these questions, and we are so grateful for this excellent talk. Thank you. Thank you again.
Thank you. It's a pleasure, and I will leave you to rest of the morning. Sorry that I couldn't join you for rest of the day, but I hope you have a lovely time, and I will look forward to the other questions that I couldn't answer, and I'll be happy to answer them by email. And
thank you so much.
Be on Twitter. Right.
Thank you.
Thank you, everybody.
You have a good day. You take care and
Thank
stay
you.
safe.
Bye.
Thank you. Bye. Right now, I'd like to remind the delegates of the break, which starts from now until 12 p.m. Please make sure to come back on time for the next speaker. Thank you. Hi again. Welcome back, everyone. Let's now welcome our second speaker, Dr. Mike Grove. Dr. Mike Grove is an associate specialist in rehabilitation psychiatry in Southampton. He's SAS lead for Southern Health Foundation Trust and oversees both clinical and leadership development opportunities for doctors. He's a member of Royal College SAS Doctors and Southeastern Division Executive Committee. He has a passion for empowering SAS doctors to fulfill their potential. Dr. Grove is going to talk to us about the ongoing challenges for SAS doctors to access leadership opportunities and help you explore ways of influencing those around in order to make your journey through the CSER process more enriching and allow you to shine during the consultant interview. Over to you, Mike. Thank you.
Thank you so much. I'm just going to do the share screen special, so bear with me. Thank you very much. Can I just confirm that that's on screen, Karen, and that everyone can hear me clearly?
Yes, to both questions.
Thank you. Hello. It's good to see you all again after yesterday's excellent clinical session. So my name's Mike Groves. I went through a period of forgetting to say no to opportunities. So I am an appraiser in the trust. I'm vice chair of MAC in our trust. I'm vice chair of the Section 12 panel committee, and I have various college roles. So I'm one of those people that take the opportunity when we can. And as SAS lead for our trust and beyond, I really do think that this is an opportunity in the next 45 minutes to, I'm having challenges with clicks as well. So there we go. Let's just put that. So we're going to go through an opportunity to find inspiration, a whistle-stop tour, if you like, of what the opportunities are. Nandini expressed so clearly the how and the what and the clinical side of things, but what is it that drives us to go for CSER, and why is leadership and influence important for CSER? We're going to talk a little bit about mindset. I'm going to go over the key sections of the consultant application form, an example of a consultant person specification, have a little think about the key people, and I'm very happy for people to put in the question and answers other key people that may be important for us all. Where are the opportunities? I'm going to touch a little bit on the NHS healthcare leadership model, and then we're going to go to questions. Why here, why now? Well, we're coming out of a pandemic, so what a great opportunity to look to the future and look towards the future of our careers and what we can do to make a difference in the NHS. I'm pretty certain that you've all been working incredibly hard. I'm pretty certain that some of you would have been shielding. I'm pretty certain that some of you would have been covering for colleagues that may be shielding, learning to work virtually, learning to work in a team in a pandemic environment, and doing the best we can for our service users. Often when we're in these sort of crisis situations, the clinical work comes first. SAS doctors are the glue that holds a lot of teams together. We are integral to service provision. And so sometimes the opportunities to go beyond that feel limited. I don't think they necessarily are, but they feel limited. So this is the GMC survey that we all know and love. I haven't drilled down to psychiatrists. I have a sense that actually there'd be more people doing activities, but if you look from the research, appraisal of others, service management and stuff, it doesn't look huge. It suggests that over 90% of us aren't actively involved in leadership activities. Why is this? I'm not sure this is quite the imposter syndrome is necessarily why, but it might be one of the reasons why we sometimes feel that our voice as SAS doctors is less heard. I certainly think that we are sometimes the most important part of the team, and I'm gonna keep harping on about that. But sometimes when you hear Nandini say 1,000 to 1,200 pages of evidence, that made my heart flutter, I must admit, and that made me think, oh, would I be able to do that? How easy is it for me to do that? That seems like a lot. And so I think that there is an element of imposter syndrome, i.e. that feeling phony, that we're going to be found out at some point, but actually we are integral to teams, and the reality is that we are all able to contribute and all able to make a difference. And with this in mind, especially coming out of the pandemic, I invite you to continue, I'm sure a lot of us are doing this, to foster a growth mindset, to embrace our challenges, to believe that we can develop our talent, to learn from experience, to take the opportunities, and to not be fixed in some of the challenges and maybe how we're feeling and tiredness as we come out of the pandemic and look to the future. And one of the things I think is really important, especially when the majority of people doing CSER want to be consultants, want to do their CCT and want to develop in their careers in that way. Some of us as SAS doctors actually just want to become on the specialist register and not become consultants. And I think that's reasonable. But looking at the how, looking at the what with Nandini, but creating a reason why we are doing what we're doing. The trusts certainly want to invest in us because recruitment and retention of psychiatrists is low, and they want us to be moving forward and to be staying within our trusts. For us, I think that it's important that we know why we are doing what we're doing. We are doing what we're doing to provide the best care for service users, but we're doing CSER because we want to self-actualize to the best of our ability and take the opportunities given to us. And if we hold that golden thread of why we're doing it, to focus on some of the challenges and breaking down those 1,000 pages into bite-sized chunks, I think that will stand us in good stead. So if the aim is to become a consultant, the job application form for the NHS looks something like this. It asks us for management of change, briefly describing changes, including audits, personally undertaken in the past 5 years. Note the 5 years, that's quite relevant for us at CSER, isn't it? Some of us would have been going along with this process nicely for a couple of years. Some of us will be thinking, shall we go ahead with it now? Whether we're doing it retrospectively or prospectively, there's opportunities to focus on some of the secondary evidence and the threads that allow us to move forward over the 5 years. Did we manage to change independently? And it says to list up to 5, and I think that's a fair ask, isn't it, over the 5 years? But the important thing is you have about 500 words to prove what you're doing in that application form. It wants you to highlight also in 500 words, management and leadership experience, how you sell yourself in those 500 words. Obviously, some of us are leaders in other fields, whether we're running clubs, whether we're doing voluntary work, etc. But that's an opportunity, and on the form, to make sure that we are highlighting our management and leadership experience. Also, our team working. So another 500 words on describing situations where you've been involved in working in a team. Again, not limited to professional activities, but this is an opportunity to shine in your CMHTs and your MDT sessions and what you've done to make a difference to that team. It's slightly slow today. Let's see how it goes. There we are. And this is the biggie. I'm not sure whether any of us have done application forms recently, but the supporting information section is around 1,500 words. And in this section, and if we're working towards the golden thread that's CSER, we need to look at a person specification. How do we meet the essential and desirable criteria for the post we're applying for? We need to be able to sell ourselves. We need to highlight our particular strengths, what makes us different, what makes us the right person for this job. So if you look at a person specification for a consultant, clearly experience here, this box is in some respects, and this box is in some respects what Nandini was talking about for primary evidence. But it's very clear that the ability to take a leadership role in an MDT and ensuring high quality care and staff morale is essential. Evidence of specific achievements that demonstrate leadership skills, essential to be able to proactively apply for these roles. There's sections on understanding the management skills required. There's sections on knowledge of NHS planning and management systems, sections on teaching, but also potentially organising in the desirable further teaching programs and multi-professional education, and a commitment to postgraduate teaching. The research and audit bits are there too. I will let Professor Crawford in the next session touch upon that. So a basic understanding of the NHS, previous management experience, evidence of leadership attributes, motivational skills, commitment to service development, excellent interpersonal skills, positive approach to job planning and the appraisal process. So who do we think the key people are that can help us on our journey? I think quite clearly, our clinical supervisor and consultant colleagues. If we have them on board, we know that our journey will be easier. We can use them as mentors, as sounding boards, and ask their advice on various matters. We can also ask if they are happy for us to step up and to take on some of the roles, including chairing MDTs, etc., and maybe some of the other roles that are implicit in the day-to-day running of a mental health team. I would say the team manager, wherever you're based, community or inpatient and beyond, is absolutely vital. What are the opportunities to make a difference to our nurse colleagues, our OT colleagues, our healthcare support work colleagues and beyond? I do think the medical director is really important. For us, the medical director in Southern Health is a local person, but obviously sometimes it's at the top of the medical tree. And I do think that actively engaging with the medical director regarding CSER, regarding expectations, regarding workforce is really important. Raising your profile and reminding people why you're doing what you're doing. I think it's very helpful, and I think this is in the documentation that Nandini was referring to, is that finding a CSER evaluator to be a mentor. Do we know who the CSER evaluators are in our trust? Do we have access to somebody that can support us on this particular level? You heard Nandini say that there are particular templates, there are particular things that our evaluators are looking for. If we're able to get it right first time and send a portfolio that is more likely going to work, then it offers more value added for us. We feel more able to commit, and we feel more confident that we're going to get an appropriate and the right result of having it signed off first time. I put the deanery there. For us, the deanery has provided leadership courses, it's provided supervision courses, it provides influencing skills, communication skills, appraisal skills, interview skills that allow us to bolster our portfolio as leaders, as influencers, that as we collect our clinical evidence, we know that we are heading in the right direction. HR, that might seem quite strange, but actually it is quite important because they are aware of the roles that are available. It's really important, I think, and I think Nandini said this, that to have a special interest day, to have it job planned with your supervisor and medical director, that you are committing to CSER. You are going on this process and you will have time to do it. HR will know some of the gaps that may be around in various posts that allow you to offer value added for a day a week, whether it's AMHT, as Nandini indicated, for more acute, for CMHT, for inpatient, but getting that breadth of experience, getting that opportunity to see clinical work, but also be involved in different styles of MDT working and leadership, I think is absolutely vital. And I think this is really important, and I'm sure you've all thought of this. Who else is doing CSER in our trust? Who else is doing CSER locally? Maybe in the deanery, the mental health, our mental health colleagues and trusts elsewhere. They are going to be a rich resource, to remind the trust and remind the divisions, etc., that we are here and this is what we're doing, but also forming action learning sets, forming opportunities to come together and discuss and to share. As Nandini indicated, the CSER process seems an unwieldy and challenging process, but it doesn't have to be, and a challenge shared is a challenge divided. If people want to put in the question and answers any other key people they feel I may have missed, I'm more than happy to share people's ideas. So seeking out those opportunities, the team opportunities, what can I make, how can I make a difference in a team? Team, for example, are there nurse prescribers that need, or blossoming nurse prescribers that may need supervision? Are there projects, are there audit projects, specific things like lithium clinics, depot clinics that you can take a lead on that show that you are have the skills and have the evidence to be able to provide that secondary evidence and the evidence for your role beyond CSER. Local, what is there at a divisional level? I say division because where I work in Southampton, Southampton is a mental health division. What can you do there? Can you take a lead on education? We have just advertised for MRC psych coordination roles, and as well as consultants, we've offered those to SAS doctors, which I think is really important. How do we empower the trust to include us in all those opportunities? So going to the trust, is there an opportunity to be an appraiser? 30% of the appraisers at our trust are SAS doctors. We appraise SAS doctors and consultant colleagues. It's a fascinating opportunity and also allows you to see what other people are doing to maintain their CPD and beyond. Regional, that might be looking at Royal College opportunities. It may be looking at teaching at a deanery level, or making a difference to projects that interface with third-party providers, for example, beyond the trust, that allow the care for service users to be optimized. National. Now, I'm not saying we should all strive for this, but there may be opportunities to go to, for example, the SAS Royal College Committee and beyond. The seeking out the opportunities and having the courage to say yes is what that. Okay, so that was a question that was for Dr. Chakraborty. I'm just checking on that. So I'm just going to take the opportunity to go through a healthcare leadership model. You may think, why haven't I chose the medical competency framework? In part because this is a more bite-sized, more punchy opportunity just to revisit some of the things that we do outside of our clinical work. This is available on the Leadership Academy. I've put some links at the end of my presentation for various things. This is part of that. So from a leadership perspective, inspiring shared purpose, leading with care, evaluating information, which I will allow Prof. Crawford to touch on later today, connecting our service, sharing the vision, engaging the team, holding to account, developing capability, and influencing for results. Okay, I'm having challenges moving that forward as well now. It's broken down into various aspects, what people feel is essential for being a leader, how you prove you're proficient, how you prove you're strong, and how you prove you're exemplary. So, inspiring shared purpose. These are things just to hold in your mind, to create a vision of the future and to reflect on, again, why we do what we do and why we are going through the CSER process. So it's valuing a service ethos. It's curious about how to improve services and patient care and behaving in a way that reflects the principles and values of the NHS. Why is it important? Creating a shared purpose, inspiring, delivering the best care for service users. So if you look at an essential part of that, staying true to NHS principles, for example, do I act as a role model? Do I focus on how what I do contributes to the end and the care of a service user? Do I enable my colleagues to have a wider meaning for what they do? Being proficient means in this case, being able to hold to the principles and values under pressure. Do you behave consistently? Do you inspire others in tough times? Do I promote the values? Being strong, taking personal risks and standing up for the shared purpose. And then exemplary, making courageous challenges for the benefit of the service. Do we have the courage to stand up for what we believe? Do I take the initiative and the responsibility to put things right? Big things, but things what I do think that we should aspire to in our CSER and potentially consultant journey. So leading with care, having the essential personal qualities for leaders, understanding teams, providing a caring and safe environment to enable everyone to do their job effectively. I think we all know why that's important, because we are part of the team affects us, the team's response and actions affect service users. How do we overcome challenges? How do we manage that dissonance, those potential splits, so we can focus energy? So, essential, things like caring for the team. Do I notice negative or unsettling emotions in a team? Do my actions demonstrate that the health and well-being of my team are important? Proficient, recognizing the impact you have on others. Do I understand the reasons for my behavior? Can I read others with appropriate empathy? What Dr. Pierce yesterday called mentalization, that is applicable to both service users and our staff and team. Strong. So strong, providing opportunities for mutual support. Do I care for my own physical well-being? Do I create conditions that allow my team to care for themselves? And exemplary, spreading a caring environment beyond my own area. So do I take positive actions to make sure other leaders are taking responsibility? Seems like a big ask, but something to strive for, I believe. Do I share responsibility for colleagues and teams' emotions? I have a slight fascination, I admit, with Brené Brown. I would wholeheartedly recommend you look and listen to her TED Talks. Her books are slightly less approachable, but Daring to Lead is an excellent example, and I would definitely point you in that direction. So I'm punctuating a few Brené Brown quotes throughout my talk. So evaluating information, seeking out varied information, using it to generate new ideas, making evidence-based decisions. Not rocket science, but important. We need to be proactive and reactive to what's out there at the moment, what's happening, so we can use our wisdom, use our hardwiring to develop our service and ourselves. So from an essential perspective, gathering data. Do I collect feedback from service users? Absolutely vital for CSER, I would have thought. Do I collect and record essential data for my area of work? Proving what you do, essential for CSER. Proficient, scanning widely, looking outside for my area of work for information and ideas that could make a difference to my current team. Do I spot future opportunities and risks and look to work with stakeholders to improve them? Strong, being able to think creatively. Now, let's face it, thinking creatively in a pandemic is really challenging. There's evidence to suggest that when we're in a threat state, to coin the compassion-focused model, it's very difficult to think outside the box. Hence, this is a fantastic opportunity today to think, okay, let's look outwards, let's see what we can do. An exemplary is developing new concepts, big ask, but over COVID times, over pandemic times, the quality improvement has sometimes had to accelerate. What have we done over the last year that's made a considerable difference? What strategies and concepts have we developed to work around the challenges of lockdown? How have we improved our pathways? Really, really important. So connecting our service. How does it all fit together? Why is this important? Because no team, no person is an island, and everything interacts. What I've noticed, and my specialty is rehab, is that lockdown has shut down opportunities for our service users, for example, third-party providers, accommodation. What is the impact on our inpatient and community service users? How do we try and unlock those, pardon the pun, in a lockdown environment? Why is that important? Look outwards, make links, see how other trusts do it. I'm part of a sustainability and transformation project that has the absolute pleasure of visiting other teams to see how they work. What are the opportunities to do that for the future? So, an essential part of that is recognizing how my area of work, your area of work relates to other parts of the system. Do I understand the system? Do I understand what the potential changes, the potential risks might be? Understanding the culture and the politics across an organization may mean you're proficient in this model. Do I know what I need to do to be proactive and to raise issues and to make well-judged decisions? It considers adapting the different standards and approaches outside my organization to my organization as a strong attribute. Am I connected to stakeholders? Am I flexible and exemplary, working strategically across systems? High flying, but why not? Do I build strategic relationships? Do I understand how complex connections across our region affect our service users and may put obstacles in place? And sharing the vision. Communicating a compelling and credible vision of the future. In lockdown times, that's incredibly important, isn't it? Being able to find a positive way forward, a creative way forward. How do we maintain our authenticity when we potentially feel less resilient, when we feel potentially under threat, when our teams feel under threat? How are we clear and consistent? An essential part of that is considered to be able to communicate. Am I visible and available in my team? Clearly, that's important for CSER and your journey beyond CSER. You're going to be asking referees, you're going to be providing secondary evidence. Do I communicate honestly and with authenticity in your appraisal for your feedback that provides rich evidence for your CSER? So proficient in this case would be creating clear direction. Brené Brown says, clear is kind, unclear is unkind. Do I help people see a vision that's achievable? Can I use a narrative, stories and examples to be able to sell that? Again, important, potentially in an interview beyond CSER. Strong would be, how do I look at long-term goals? Do I encourage others to fulfill their goals? Do I establish strategies and communication that allow us to move forward through challenging times? And exemplary, Again, aspirational, but hey, shoot for the sky. Do I display confidence and integrity when I under the microscope? Can I look at the future and describe the future? Can I justify potentially complex and maybe more controversial plans? Trust is earned in the smallest moments. And I would add to that, I think every single conversation is an opportunity to make a difference, whether that's service users and staff. And from a positive psychology perspective, from a hardwiring perspective, when you're on your CSER journey, each of those little bits of the jigsaw add up. So engaging the team, making sure they count, making sure they feel that their voices are heard, making sure that they understand the future and they are willing to step up. Clearly, if you have a happy team, a team with focus, I'm fortunate, I work in rehabilitation. Often that means we have a delineated role and a fairly clear mission statement. In general adult, in AMHT, it may not be so clear. There may be issues with patient flow and beyond that add little splinters that mean that we have to find ways of overcoming these and moving teams forward. So essential, clearly essential in this case is involving the team. Do I appreciate others? Do I listen attentively? Secondary evidence, referee evidence, that's all going to be rich and allowing you to move forward beyond CSER. As proficient, it suggests fostering creative participation. Do I ask for feedback? Do I encourage my team to identify problems and solve them to themselves rather than being a hierarchical medic? A strong example of this may be cooperating to raise the game. Do I enable my team to feed off each other? Do I encourage team members to get to know each other's Myers-Briggs, the pressures they're under? Exemplary, in this instance, is stretching the team for excellence and innovation. I'm fortunate enough to be part of an outstanding team from a CQC perspective. And one of the things that I would say is that we're a happy team and we know where we're going. So do I support other leaders? Do I stretch my team to provide a brilliant service? Do I create a common purpose? Do I encourage my team to deliver on that purpose? No questions and answers, but feel free to add anything you want. Another Brené Brown quote. And I will answer that question, Nicholas, at the end of this. So, daring leaders work to make sure people can be themselves and have a sense of belonging. So, I'm going to go through a couple more with your permission. We're nearly there, and then we'll talk a little bit about the future and the next steps. So, holding to account, agreeing clear goals, knowing where you stand, knowing the direction, supporting our colleagues and teams to take responsibility. Essential is setting clear expectations, personal responsibility, making tasks meaningful for our teams, making sure they're smart. Proficient, managing and supporting performance. Do I challenge ways of thinking and encourage people to look at data and look beyond? Do I have clear standards for my own behavior? Do I embody what I expect of people? Do I give balanced feedback? I said that I believe every conversation is an opportunity to make a difference. If you take a coaching mindset, we can find a positive way forward throughout our conversations. Do I spot when things are going not so well? And do I nip that in the bud? So a strong version of this is challenging for continuous improvement, looking for opportunities to celebrate. I'm here today celebrating SAS doctors, as far as I'm concerned, and the potential we have. Do I notice and challenge when things are not so good? And here comes the mindset bit for exemplary. Creating a mindset for innovative change. If we can create a mindset in ourselves, can we allow that to be instilled beyond? Do I share the stories of success? Do I champion the mindset? Do I encourage a climate of high expectations, reaching for the stars? A classic Brené Brown. It disappeared too quickly, but you will see it in the slide set. So developing capability, acting as a role model, championing learning, championing knowledge. So providing opportunities for people development, teaching, nurse prescribers, and beyond. Do I understand the importance and impact of allowing people to self-actualize? Proficient, taking multiple steps to develop team members. Do I provide development opportunities for other people? Do I look and provide regular, positive, and developmental feedback? A strong trait in this model is building longer-term capability, looking to the future, engaging with other people's career aspirations. Can I provide a mentoring opportunity for my colleagues? Can I spot high potential colleagues and allow them to shine? I'm absolutely certain that there are people that are with incredible skills out there that are beyond mine, and I really welcome the opportunity of allowing them to develop. So exemplary in this case is creating systems for succession to all key roles, looking at our teams as a whole, making sure that your team is able to move forward. Brené Brown again. Final one for this model, and I appreciate your patience and attentiveness. So this is about engagement, positive impact, building relationships. The reason why there's a jigsaw puzzle and a cube is because they're all interconnected. Am I respectful is essential. Do I listen to other views? Do I develop and present well-reasoned arguments? If we're proficient, we're adapting our approach for diverse groups. Do I change the way I communicate? Do I check that others have understood me? All important for secondary evidence and referees and life beyond CSER. A strong trait for this would be developing collaborative agendas. Do I use the networks I have available? Do I engage stakeholders? An exemplary in this case, building sustainable commitments. Do I contribute productively to debates? Do I build support for ideas and initiatives to allow them to shine and grow? Thank you. Brené Brown again. I make no apologies. Right, I'm nearly there, Fatima. So developing those skills. So let's face it, certain leadership skills will come more naturally to us. What they say on the college website and beyond is to plan, find the small step, what is possible in your work environment. Do something, try something small, study, reflect and seek feedback, act and decide what to do differently. So developing those skills, seek out a mentor. A mentor is somebody you specifically seek out for a specific purpose, not a coach just to talk you through your life and to get to a goal, but these are mentors are specific people. Is there somebody that can specifically help you with CSER? I say engage with your SAS lead and find out what your trust and deanery offer. So next steps. There's loads out there. I refer you to the medical leadership competency framework that I talked about earlier. It's a fantastically rich read. There are programs, the Leadership Academy, the King's Fund, and there's a fantastic online resource for all of us, for our IMGs and beyond, about how the NHS works. Leadership development on the Royal College site, I point you towards that. So I say, seek out a mentor, engage with your SAS lead, find out what your deanery offers, and on your CSER journey, embody being a consultant. How do you make a difference and sell yourself beyond your next steps? And Fatima, that's all I have to say on that.
Thank you so much, Mike. That was really very empowering and excellent presentation. Thanks a lot. We haven't got basically many questions, but I just wanted to, for probably 1 minute, if I may, just ask the question about, often heard in the past that SAS doctors are for the service delivery. And I wonder, what's your opinion in basically these kind of barriers in facing SAS doctors in engaging within leadership, objectives or tasks?
I honestly believe there is no block. And I believe that we should be cheeky. I believe that we should ask questions. I believe that we should ask our SAS leads, our chief medical officers, our chief executive, do you know them by their first name yet? If not, get to know them. It might sound twee, but actually it makes a difference. There is no reason why it shouldn't be the right doctor in the right role. Okay, and that could be an SAS doctor, it could be a consultant. But if you've got a niche of expertise that allows you to move forward with CSER in this particular case that we're talking about today, then you should be allowed to do that. I'm not suggesting that I'm not lucky in my trust. Culturally, we've worked on SAS doctors being empowered, and we don't say consultants, we say senior medics now, okay? There's a question, if I may go, Fatma, on CSER not being a priority. We completely agree that CSER isn't the be-all and end-all, is it? What I've talked about is us being the best doctors. There's SAS doctors by choice. Some of us don't want to be AC clinicians. Some of us don't want to be Section 12. Some of us don't want to be on the on-call rota. We have many and varied lives and reasons for doing what we do. Some of us are carers. Some of us have our own challenges. We should just be and have the opportunity to self-actualize to the best that we can and make a difference. The good stuff, the leadership stuff, makes the clinical stuff worthwhile, as far as I'm concerned. Yep, and I think basically you're quite right. If you provide a development program, a leadership program for everybody, then CSER can run parallel to that. What advice do I have for locum doctors, Fatma? Engage with HR, engage with clinical directors, and try and make it work. But it's difficult because the locum will be very specifically for service provision, and I do understand the challenges that you have for that. And thank you so much. I would like to hear Dr. Grove speak again. Okay.
Thank you so much. Thank you so much, Mike. That was really very stimulating presentation. Thanks a lot.
Thanks, everyone.
Yeah, so shall we just move swiftly to welcome our next speaker, Prof. Mike Cromford. So Mike Cromford is a professor of mental health research at Imperial College London and an honorary consultant psychiatrist at Central and Northwest London NHS Foundation Trust. He's also the director of the Royal College of Psychiatrists Centre of Quality Improvement, where he oversees a program of quality improvement initiatives, including accreditation services and national audits. In his presentation, Professor Crawford will provide a short introduction to clinical governance and provide an opportunity to share the ways that people engage in these activities and factors that support effective involvement. Over to you now, Professor Crawford. Thank you.
Thank you, Fatma. I've just been enjoying the last presentation, and Mike is such an eloquent speaker, and there's so much wisdom in his presentation there. This session isn't going to be about any attempt for me to be wise. It's going to be a brief introduction to clinical governance and an attempt to, using Mentimeter, get us all to share our experiences of involving ourselves in clinical governance issues, what works, what doesn't work, any tips we can do. I've only got a small number of slides, so it really is going to be a question of people sharing it. I don't know, I imagine some of you have already used Mentimeter or some other online platform that allows you to share views and take part in online polls. But the success or failure of this will depend very much on your ability to and willingness to kind of engage in it. So please don't leave me dry. Do get your mobile phones out, and when the number pops up with the website, you'll be able to answer some of the questions that I've got in here. Okay, so I'll start the presentation. And yeah, thank you for that introduction. Yes, I'm Mike Crawford, and I'm a consultant psychiatrist and a researcher at Imperial. And I was asked to get involved in this presentation because of my role as director of the Centre for Quality Improvement at RC Psych. I don't know if some who are on the meeting today will have come across some of the national audits, like the National Audit of Psychosis or Dementia, or POM, the Prescribing Observatory for Mental Health, or perhaps some of the quality improvement networks and accreditation services for inpatient and outpatient mental health services. So I'm involved in that program at the college, and I'll refer to that a bit. I'm not going to promote the work of the college particularly, but I'll refer to some of the college programs because I think some of them can support our work as doctors and our involvement in clinical governance. We are all required by the GMC to be involved in clinical governance, and we all struggle because of the demands of our lives, the demands of our clinical work, and the frontline work that we do. But there is some evidence that people who are SAS doctors and locally employed doctors struggle to get involved in clinical governance more than others. And I'll mention a survey that was done by the GMC a couple of years ago to provide some evidence about that, before going on to think about the components of clinical governance. And as I say, hopefully engage you in sharing some thoughts and information about what works better and not so well. Okay, so clinical governance is simply a framework to ensure that NHS services are accountable and safeguard the lives and the health of patients. An awful lot of things in medicine and medical policy come and go quite quickly, but clinical governance has stuck around. It's been going now for more than 25 years. And I think that's because at its heart, it recognizes something very important about the role that we have as doctors and as part of our teams to make sure that patients benefit from the care they get and certainly aren't harmed by it. And it has its roots in some of the concerns that were raised around instances like the Bristol heart scandal that you might be familiar with, which was essentially a team that thought they were doing well, but actually had dreadful outcomes in terms of heart operations for kids with heart difficulties. And there have been various attempts by people to raise concerns about this, but the team thought they were doing a great job. And it wasn't until there was an inquiry that it emerged just how badly things were being handled within that team. So the GMC and its responsibility for overseeing the work of doctors said, look, we need to put things in place and we need to make a commitment for every doctor and every organization to be involved in being accountable for the quality of the work that they deliver. So what are our responsibilities as doctors for involvement in clinical governance? Well, these shouldn't be unfamiliar to you because these are the basic requirements of registration with the GMC, that we should keep our professional knowledge and skills up to date, that we should be familiar with the guidelines and developments that affect our work. Importantly, that if we see something going wrong, we do something about it, and I'll say a bit more about that later on. And that we need to take steps to maintain trust in ourselves, in our profession, through working in a way that's open, honest, and with integrity. We all need to participate in revalidation, and the organizations in which we work have to have processes in place that protect the lives of patients, and we need to make a contribution to ensuring those are successful. Okay, so I hope some, or maybe even all of you, have got access to a mobile phone so that you can help with the slides, which are more interactive. And the first question for you is, which of these activities related to clinical governance have you been involved in over the last year? Continuing professional development, audit and quality improvement, governance committees, research, and raising concerns. So if you can go to that website, just go to menti.com, and it should ask you to put in a number, 23997361, and if you can have a go at entering that, I'd be grateful. So with this question, you can answer as many times as you want. So if you've been involved in all those things, then tick all those boxes. Well, that's a relief to see that someone's got a mobile phone. Fantastic. So yeah, some of the questions you can only answer once, but with this one, you can answer as many times as you want. Okay, so we've got 12 responses so far, 14 responses, and it looks like everyone who is able to respond to the question, all but one, have been involved in continuing professional development. And really, it's quite hard not to be, isn't it? Because the opportunities for reading a journal article or attending a scientific meeting or a conference like this are multiple, aren't they? Okay. Thanks, everyone, for giving some responses. This gives me a chance to see what you're doing, but also gives a chance for you to see what you're doing in relation to your colleagues. Okay, yeah, so CPD is a kind of given, isn't it? Nearly everyone, you know, it's really hard not to make the opportunity. We all have questions that we get surprised by. I was asked recently about a patient who was concerned about osteoporosis, who was taking SSRIs and needs to take a look at that because I wasn't aware of it, but kind of found out about which antidepressants may be more associated with the onset of osteoporosis. You can't be expected to retain all that information, so you need to pick up a book or go online and find out answers to questions. But it looks like about half of the people who are at the conference who've responded have had some involvement in audit or quality improvement, and of course, in recent years, QI has really sort of taken root in many of our services, and so it's good to see that people are involved in that. And actually, I'm really kind of pleased, and to be honest, a little bit surprised that a third of the people who've responded have had some involvement with raising concerns, because I think that's one of the more difficult aspects. Clearly, research is a bit more complicated. Clinical governance committees are a minority, but it's great to see that everyone's involved in CPD. About 2/3 have been involved in the last 12 months in some form of audit, and that a third of you have been involved in raising concerns. So this next question is a question which allows you to put in any free text that you have, and it's a question about barriers to participation in any of those CPD activities. Now, imagine that some of the barriers, say, involved in raising concerns would be different from those barriers involved in getting involved in audit or just reading up material that's relevant to your practice. But I'm trying to get a sense from you about if there's been an aspect of clinical governance that you have wanted to make a contribution to, but haven't been able to, or you've tried to get involved in something and it's not been successful. What is it that's got in the way of you trying to do that? audit takes a lot of time. Surely it does, yes, especially if you do it properly, which means more than one round of audit cycle, doesn't it? Collecting data, identifying the question, yeah, it takes time. I'll say a little bit more later on about things which many of you will be familiar with, but things that are aimed at trying to get the most out of your involvement in audit. Short staffing level, not aware of what to do, yeah, time, yeah, okay. Working as a locum doctor, yes, yeah, yeah. Okay. Yeah, so I think we're getting, okay, it's interesting we've had a comment there about line manager, and maybe that's about whether or not there's support for you to get involved in clinical governance activities. But of course, you know, audit is a key part of clinical governance, and clinical governance is not an option, it's a requirement. I think a lot of those issues that are being put in there are to do with time and some to do with confidence. Okay, so maybe we can think a bit more about that issue of confidence at a later point. Thank you everyone for responding to that question. Yeah, so I was saying that everyone struggles to find time to do things that don't involve seeing patients in direct clinical activity, but there is some evidence that SAS doctors and locally employed doctors have additional barriers. The GMC investigated this a couple of years ago in a large-scale survey in which over 6,000 SAS and locally employed doctors took part across the whole of medicine. And like we've just found out there from that quick survey, most people say, you know, they're able to maintain their skills, you know, whether that's through reading journals or attending meetings or whatever, that's something which most people are able to do. But when it came to clinical governance, you can see from this slide that almost half of people said that there'd been some kind of barriers to involvement in CPD. And at the bottom of that slide, you can see that only 10% of SAS and locally employed doctors were involved in clinical governance activities. Of the ones that people were involved in, audit, teaching to a lesser extent, but many had had no involvement in responsibilities other than providing direct clinical services. So CPD is the easy one, isn't it? Or I say the relatively easy one, although I have many friends who tell me about all their copies of the BMJ or the BJ Psych that lie in that kind of uncomfortable pile in the corner of the room waiting to be opened. The GMC says it's not just about doing something. You need to think about what you're doing and think about what you get from doing it. And there's a document produced on clinical involvement in continuing professional development a couple of years ago, which really emphasized the importance of reflection. So it's not just about reading something, it's about working out what you need to know. That doesn't just mean your own ideas about what you need to know, but also speaking to your team and your colleagues, because there may be expectations that you will be a source of particular assistance or expertise in a topic that the team needs you to be expert in that might help direct your learning. And also this issue of reflection, which I find quite difficult, you know, because as I say, the other day it was which antidepressant is best in someone who's very concerned about osteoporosis, and you kind of find out an answer to that question. You don't really need to reflect on it. Nonetheless, it's not just about doing the reading, it's about trying to consider what you've learned and putting that into practice. Okay, so another question, and I think this question only allows you one response, so think carefully before responding. Which of these have you found in the last 12 months to be most helpful in terms of your continuing professional development? So you may have done all 4 of these. You may have done private reading, you may have looked at medical journals, you may have attended a local academic or clinical program, or you may have attended regional meetings like the one you're attending today. Which of these do you think has been the most useful to you in the last 12 months in relation to your personal development and reading? Okay. No one's saying medical journals. Do people read the BJ Psych? Do people read the psychiatric bulletin? Private reading, yeah, okay. Well, so there's quite an emphasis there on local and regional programs. And of course, you know, it is really helpful, isn't it? Because we have to account for our learning, we have to put it into our validation, and finding the time on a weekly basis to do something like private reading is tricky. And regional meetings like the one you're attending at the moment do allow you to say, okay, I'm going to take time at my clinic, I'll let everyone know, try and get some cover or whatever. That day I'm going to be doing this. So it kind of becomes a bit more protected, particularly where you're balancing times demand on your time from home activities, work activities, and all the rest. But not a single one on medical journals. Maybe there's something wrong with medical journals and the way they present their information. I quite like looking at the BMJ, which I think has found a way of presenting information in quite digestible ways that don't just involve research papers. Maybe there's something that BJ Psych and Psychiatric Bulletin can learn from that. Thank you. Someone's looked at medical journal. Okay. It says something for us researchers as well, to remind ourselves that we do all this research, and then do people actually see it, or how do we talk to people about the results of our research? Okay, this is another free text option. You can type anything into that box you want. I'd like you to share something that you think is a great source of CPD. So we've covered things like obvious things like attending a regional or a local meeting. Is there a particular website that you use that you find really helpful? Is there a book that has really helped inform your practice and change the way you work? Is there a particular conference that you'd say, do you know what, if you're going to go to a conference next year, which conference should it be? CPD online, webinars, yeah, okay. Do we have any other suggestions from people about a really useful source of CPD? Online learning modules, college CPD online, Wow, this is looking good for college CPD online. International conference, nice website, podcasts, yeah, great, okay. Yeah. Well, look, I think several of those suggestions are ones that I would also highlight as being particularly useful. I'm glad that people have mentioned the CPD online modules at RC Psych, which I think, there's a huge range of them. They're regularly updated, and they are designed to cover the topics that people are most concerned to read about. I'm going to put a few of my favorites on this next slide. I saw that someone put down the nice website. I'm sure you will look at the electronic BNF online, which I look at nearly every day I'm in clinic. And that website's actually part of the NICE website, which also includes the NICE guidelines, NIHR alerts, where if there's a new piece of research that's really said something quite clear, it's a chance to see what the latest things are, because obviously it takes like 6 or 12 months for those things then to work their way into things like BNF guidelines and NICE guidelines. So plugging a little bit of my own research, a couple of years ago, we did a big trial of mood stabilizers in borderline personality disorder and found that they make zero difference. People who took the mood stabilizers did very well, but people who took the placebo did just as well. Taking a placebo was really helpful for people, but taking a mood stabilizer was no better. Now that's going to take, it might take another 5 years for that to get into NICE guidelines, but it's on the NIHR alerts. So if there's a big study that's come out, so that's a quick way of seeing it. The Cochrane, of course, provides really trusted, balanced information, really trusted source of high quality information from systematic reviews. You don't need to read the whole review. They've got good abstracts where they'll be saying there is evidence this helps or it doesn't. A number of you have mentioned, of course, those two are free. Some of them charge. Several of you have mentioned the CPD online modules available from the Royal College of Psychiatrists. £75 a year, which is not substantial, but it compares well with perhaps with membership of professional organisations and what have you. Mental health is also good. You have to pay £60 a year for that, but that really does provide, I think, information in a readable and engaging way, and maybe some of you access that site as well. But what I wanted to make the point was that I think what you use, when you use it, what you're looking for varies a great deal depending on your circumstances, and things change, don't they? So some of you might be doing jobs where you need to know more about psychotherapy or pharmacological treatments, or circumstances change. And I put down this book because at the start of the pandemic, I'd been working in a specialist service for people with personality disorder, but like a lot of people, they needed help in the trust. I was saying, how can I help? And I was asked if I could work in a single point of access service, which I'd never done before. And suddenly I found myself speaking to many, many patients who often had non-psychotic mental health conditions, but complex physical health conditions. And I've been using this book so much in the last year. It's been so helpful. I've done more CPD in the last year than I've done in previous years because I'm doing a different role. And that's been my particular favorite source of information. But you have to pay for it, obviously. And it's a good resource. BNF is fantastic as well, obviously. Okay, so it seems like 2/3 of you have been involved in some form of audit or quality improvements exercise, quality improvement project, and really the amount of QI work that goes on in trusts has rocketed in the last few years, and many of you will already be familiar with the model for improvement and various other methodologies that are used within the QI umbrella. I suspect that rather than leading QI projects, we're often asked to get involved in other people's QI projects. And that's really good because the outcomes that we deliver for patients are delivered by teams. So that makes sense for QI projects to be delivered as a team as well. And I put on this slide some resources for those who want to find out more about QI, about the basis for QI, about the methods that are used. I mean, there's a wealth of good quality, free information out there about how to plan and develop QI projects. I'd really recommend the BMJ podcasts, which can be accessed through the bmj.com website, Quality Improvement, which I think really, in a succinct way, provides some very helpful information on this topic. Okay, well, I want to think a little bit about audit, and this is one of the areas that many of you have already been involved. I don't think I've got too many of these. These might be my last interactive questions, so thanks for everyone for keeping populating these slides, but this might be one of the final questions on. For those of you who've been involved in an audit, could you share a suggestion or a tip for other people that you think helps audits succeed? We had some qualitative comments earlier on about how time-consuming audits are, particularly with the other demands on time. But I'm sure some of you will have been involved in successful audits, and some of you have been involved in unsuccessful audits. And I can certainly say that over the last 20 years, I've been involved in both successful and unsuccessful audits. So what would you be saying to a colleague who says, look, I haven't done an audit, I need to do one, I've been doing revalidation and I've got to get some audit under my belt, what are you going to do? And we've got suggestions here of good teamwork, easy access to data, relevant to all the team, simplicity, getting help. Yeah. Set aside time, work as a team. Yeah, the word team comes up more than once. Clear objectives, clear goals. Yeah, make it relevant to your own work. Okay, you'll probably see different patterns in there to me, but the three I'm seeing are make sure it's relevant, work as a team, and have a clear objective, which is simple, for which you can access data. And I think if you stick with those four things, which are very present on that slide, you will do well. It's too easy to have a topic which is of interest, like community alcohol detoxification or patient experience on inpatient wards, and it's too vague. It needs to be made more specific. You're not going to be able to complete a successful audit unless you've got colleagues in your team who also believe it's important. Actually, you need to believe it's important, otherwise you're going to give up on it. And then you've got to think about what is measurable and how can you get some source of data, and that's often a sticking point. But there will be people in your service and people in your trust who can help with that, whether that's through using routine data. We have a system here called Tableau, but there are other online systems that are already tracking some of the routine data. Making sure that you don't set yourself a task for collecting too much data, becomes overburdensome and isn't completed. Yeah, you know about the audit cycle, identifying a clear topic, setting a standard, collecting the data, analyzing it, and implementing change. It's the implementing change, actually, which is sometimes the tricky bit, which I think is why increasingly people are turning to QI methods rather than simple audits, because of the focus within QI on change. But having said that, a good audit is still able to deliver change for patients. It really is about the investment in time that you put into changing something. Another tip that hasn't been mentioned is, which is worth briefly considering, is that we know that audit improves practice. In fact, there have been randomized control trials of audit versus no audit, and they have shown benefit. And the two things that really make a difference are choosing a topic that's a problem and thinking carefully about how you relay the information and do the implementing change. The thing about one of the important things about audit is if the practice is okay at the start, it's very difficult to demonstrate change, to achieve change, because things aren't bad. So you do need to pick a topic where performance is poor. I wanted to briefly mention the national audit program that's run by the Royal College of Psychiatrists. I don't know if you have come across things like the Prescribing Observatory for Mental Health, the National Audit of Psychosis. There's a new national audit of memory clinics, which is starting later this year. And there's likely to be a national audit of eating disorder services, which will start up next year. The reason I mention it is because it's good to be involved in audit from the perspective of developing your career and your interests and your CV. One approach is to get involved in a local audit with your team, which is fantastic. But another approach is to offer your services to the central audit team in your trust, because they often are looking for help with collecting data, communicating results, and working with audit leads in the trust around the National Mental Health Audit Programme. So that means you can be involved without taking the full responsibility for the audit. Okay, different topic now. Committees. And I think this was one of the areas that people indicated that had less involvement than others when we started off with that survey. Again, in terms of developing your CV, making a contribution towards clinical governance, getting involved in some form of quality committee is a useful thing to do. But I don't know what your experience has been like, but my early experience of joining trust committees was a rather confusing one. And speaking to colleagues, I think they also often feel confused. Now, there are still trusts and there's still committees, operating trusts, that don't have clear terms of reference. So you find out that there's a committee going on, there's a vacancy, someone asks you if you'll get involved, and you get involved, you suddenly find yourself sitting among this large group of people, either in a room or obviously at the moment online. And you know, unless there are some terms of reference for the committee, it's quite difficult to work out what is going on. And even when there are terms of reference, my experience has been that there's a kind of implicit and an explicit role for many committees. So trying to work out what the point of the committee really is and what their aim is isn't as straightforward as it should be. These are just based on some of my own experiences and those of colleagues I've spoken to, but you know, a bit like doing an audit, perhaps starting off with a clear aim. If you're going to be on a committee, try to get a clear understanding of what the aim of that group is, both implicit and explicitly. Also, if you do join a committee, it can be a little bit disorientating at first, but it can take a bit of time. So I think it's good to make a commitment to trying to attend a committee on a regular basis for a while, so that you can look to other people in the committee and see how the committee is functioning in order to get a better sense of what makes a difference. It's really important to build up your confidence if you're attending a committee for the first time. And, you know, I think the only way to do that is to try it out, you know, to start making a contribution and to prepare for the meeting, because there will often be documents sent around beforehand. Unless you've taken a look at those, you know, try to take a look at the documents before the meeting. Try to see if there's something on the agenda of the committee that you feel you can bring some of your experience to, or suggestions to, or something which is of importance to you that you want to ask some questions about or try and find out more about. There's an awful lot of hot wind in hot air in committees, so you know, avoiding too much talking and trying to help the committee to be more solution focused. Another trap of committees is that there's often work to be done, and someone who comes along as enthusiastic will be given too much work and quite quickly get overwhelmed. So try to focus in on something you're going to try and do within the committee structure, but don't take on too many interests. Try and get involved in something that matters to you, and use the committee also to help build your relationships and network with colleagues. Research was the other one that few of you tick the box for involvement in clinical governance. And I'm not surprised, because it's all rather elaborate, and the whole process of doing research has become much more complicated over the last 20 and 30 years with greater governance of research processes. So there was a time when you could do stuff and get it published without even going through a formal ethical committee approval. But the process of going through ethics is a major task, and not one to be embarked on too lightly. Having said that, of course, in all trusts there's research going on, and you've probably heard about a project. It might be simply a question of you helping patients become aware of a research project that's going on. You might want to get more involved, and a key area is in terms of supporting recruitment. And there are free online trainings at the NIHR website for those who want to undertake good clinical practice training, which will prepare you better for recruitment of patients in studies. There are other research activities that you might get involved in through your local R&D office. So for those who are interested in research, do check out the research website of your trust and contact the R&D department, because there may be a specific task that you get more involved in, which again doesn't mean taking on responsibility for a whole project. I think it's unlikely, it's very rare these days for a full-time clinician to undertake their own original research. There may be some opportunities for writing up service evaluations and quality improvement projects, that's a way of kind of getting publications as well. But when it comes to empirical research, asking you questions, addressing hypotheses, it really is such a palaver that most people are put off from it, but will be more likely to support other people in their research. But if you are interested in doing that, I would recommend your local R&D department and your research design service. The RDS, the research design service, there is one for each region, usually based at a university, and they are paid by the government to support frontline clinicians to develop research ideas and research proposals. So do use your research design service. Yeah, for those who do get involved in projects, and certainly where I work, I know in the region you're working, there are active research projects. Where people do get more involved, there are opportunities to contribute to publications, sometimes through the secondary analysis of data. So know who your local academics are, check out what they're doing, and see if you can get involved if you're interested in doing so. Okay, so the final point I wanted to raise was about taking prompt action if there are concerns, if you have concerns about patient safety. And I do have one more vote, I think, before we finish up on things. If you see that someone is not receiving basic care, you need to tell someone about it straight away. If you see that someone's not being treated with respect, you need to speak to someone straight away. If people are being given basic care, but you have concerns that the care is not of a high enough standard, you have an obligation to do something about it. But doing something about it is not straightforward. It was kind of reassuring to see that a third of you had raised concerns about patient care within the last 12 months. I've done that too. And of course, what you do in the first instance is you speak to a senior person in the team, a manager or a consultant psychiatrist, someone else, and say, look, I've got a concern about this. In the service I'm working, we have a time in the early evening where we have more dropped calls than at any other time. So we've been speaking to our manager about trying to reorder the shifts in order to make sure there are more staff in there, because it's a concern to me that people are ringing up in a crisis and often not getting through. But what happens if you don't get the response you're looking for from your local team? Well, you should all know about your freedom to speak up guardian in your trust, and they have a role to support people who don't feel that patients are getting a fair crack and that people who raise concerns have been listened to and action taken. So you can speak in confidence to the freedom to speak up guardian in your trust. And if that's unhelpful, then there are other sources of support, including medical defence unions, the British Medical Association. There's a charity called Protect. I've got the number on that slide there. And there's also a helpline that anyone working in NHS or social care services can call in order to talk through a concern you have about a patient's safety or dignity issue that isn't being properly managed. But you've probably read or heard about examples of people raising concerns and it being difficult. And the sad truth is that some people who raise concerns do not always get a good response to those concerns. The important thing is to work with your local team and with your peers in all instances to try to resolve problems. But on occasions, problems do need to be escalated, and we need to know how we can escalate them. Yeah, so this is my final voting question, but I'm interested in whether, several of you have raised a concern, and this question asks you to give one response to whether or not when you raised the concern, it was resolved or not resolved, or whether you had to escalate the concern beyond your local team, and if so, whether it was resolved or not resolved. And obviously this is entirely confidential and I don't know who's responding, it's not identifiable in any way, but it is a controversial question, isn't it? Because if people had escalated concerns and they weren't resolved, that would be a problem. Many of you won't have done this, but I think about 10 of you did. We've already got 9 responses, so that's good. And what that is showing is that, as with the guidelines, you've been raising those concerns locally, and in about half of instances they've been resolved, and in half they haven't. And it's good to see that when concerns have been escalated, there are examples of when they have and haven't been resolved. I mean, some things are fundamentally problematic, aren't they? Like, you think about the quality of a building, you know, about sort of not being able to have disabled access to a ward or something, and there are clearly no easy solutions. But that is to be expected. Most of the concerns are being raised locally. Actually, more have been resolved than not resolved. And when they have been escalated, they've been resolved. I find that kind of slightly optimistic in a way. Firstly, it's really good to see that people aren't turning a blind eye. That's what the whole business of this is. Don't turn a blind eye. It's good to see that most of the issues are being raised locally, and that more than less are being resolved at a local level. And it's good to see that people have taken action when they haven't been resolved at a local level, and spoken to others about them. And again, not all resolved, but many of them have been. So look, in preparing this presentation today, I was reading through clinical governance, and the one that slipped my mind probably was the issue of raising concerns. Actually, I think it's one of the most important things that we do. So it's good to see that people are doing that. Oh my goodness me, I did promise you that was the last question, but we do have one more. It is, I'm sure this is the last question. Oh yes, it is definitely the last question. Okay, just a simple answer. Do you think you're doing too much CPD, quality improvements, clinical governance, doing just the right amount, or doing too little? Okay, are you doing too much of this stuff, too little of this stuff, or on balance, do you think you're doing the right amount? I'll just let a few more results go through there. Yeah. Well, that is very encouraging, isn't it? And I'll go on to the final slide, because, you know, we all have a responsibility to maintain our knowledge and our professional development. We have a responsibility to raise concerns, as it sounds like most people are doing. And we have to support the clinical governance activities of our trusts. But the truth is, we also want to balance our work and our life. And, you know, I know some people, particularly people at universities, who work all hours and really don't have a life because they're so committed to their research and their activities. But, you know, I think a healthy life is obviously one that has a better balance between the work activities and other activities. And it sounds like many of you are sufficiently involved in clinical governance activities in order to be fulfilling the GMC requirements, but also protecting your work and your life. And that's good to see too. So I'm going to end the presentation there, and I will just see if we have any questions. I think we're also due to finish in a couple of minutes, aren't we? So do stop me if I stop there. Private reading and regional meeting, yes. Medical journal, but that is in private reading, yeah. Maudsley webinars, yeah. Maudsley webinars are excellent, aren't they? CPD online. Regular use of NICE guidelines, yeah. And I'd really recommend, you know, when you go to the BNF, electronic BNF website, that does give you access to both the NIHR alerts and the NICE guidelines. I would suggest looking occasionally at the NIHR alerts. I'm saying that obviously if someone's doing research, because, you know, it can take a year, it can take 5 years for research findings to weave their way into clinical guidelines. So it is worth keeping an eye on other issues. Now, can I go? Oh, maybe I need to go. Oh, hang on, done. Okay, sorry, I'm just trying to get to the ones at the bottom. See if there's anything missed. Reaudit, the primary audit. Yes, that's a really important aspect, isn't it? Thanks for yes. Okay. Well, look, I don't think there are any more questions, and it is just about 1:30.
Thanks, Crawford, for this really lovely presentation, very interactive as well. As I can see, there are no really questions, but I've got one for you, if you don't mind. What if we raise a concern about basically patient's care and none is done about it? What would you advise, please?
I would advise speaking to your Speaking Up Guardian. And if you go to the Trust website and just Google it, you should quickly find out who that is. I actually just did that this morning just to see if I could find my local Speaking Up Guardian you can do. That's usually a person who's a non-executive director on the Trust board, and they are the kind of touchstone for, so that they're regularly speaking to people, nurses, psychologists, doctors, about concerns, and then they will be speaking to the management team, the local management team, or their managers, and they're usually quite effective. Now, there are some issues which can't be resolved very easily, and so the response is, we need to build a new hospital or whatever. That's not going to happen soon, is it? But I would recommend that. There is also that confidential whistleblower helpline provided by the NHS. But the other thing is, do speak to colleagues. We all need to have a peer group, don't we? And I wouldn't do any of this without having a friend, without having someone who's I'm on friendly terms with. We need to go to our peer support group, don't we, and say, do you know what? This is a worry for me because we've got a problem here and it's not happening. Sadly, when you speak to colleagues who have done this, there are times when it doesn't go well, and you kind of need the moral support of your peer group as well.
Thank you so much. That was very illuminating presentation. Thanks a lot. So now, obviously, we are coming to the end of this fantastic event, and I would like to thank all the speakers for their excellent presentations. Thank you for all those behind the scene, Karen Morgan, Sophia Vega, Ashley Calloway, Mike Grove, and thank you also very much for Mike for co-leading. Thank you for the delegates for attending the event. Hope you all enjoyed it and gained so much knowledge. Please do not forget to complete the feedback form. A link will be provided in the chat, but will also be sent out separately following the event. We will now be closing the event. Please stay safe and stay well. Thank you.